All right. Thank you. Good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. I'm your chairman, Jocelyn Peña-Melnick. This is our first session back in person since 2020, so I ask for your patience if we encounter any technical or streaming issues. It is not the fault of staff. They do their best. It just happens, okay? And this is the first year that we're doing virtually, right? Virtual and in person, so we're trying to be accommodating to everyone. You're going to see that our members some are not here right now because they have bill hearings in other committees, or they'll come in and out because they've been called to cover another committee. It does not mean that we're not paying attention. Also, if you submitted written testimony and you're not here, we read those and they are as important as the oral testimony as well. Please set your electronic devices to vibrate, and I'll have to check to make sure that I did it. And it's done. Make sure it's on vibrate, and don't hold conversations in the committee room while testimony is happening. We're going to hear from the bill sponsor and the bill sponsors panel, followed by all in-person witnesses. So it's going to be this way. The favorable will be called first, favorable with amendment, then the unfavorable. It just makes it easier. Then all virtual witnesses will follow the same outline. The bill sponsor testimony is not limited, but please don't take more than 10 minutes, okay? Don't take a long time, because I will ask you respectfully to wrap it up. While all witnesses will have 2 minutes to provide testimony, and that is 2 minutes, not 3. So when it goes off, please listen to that sound. A timer is displayed on the screen, and a sound will be played once your time has expired. I'll give you a second or two to wrap your thought, okay? Please adhere to our usual committee rules of 1 question and 1 answer from the panel. Now, 1 question and 1 answer from each witness. And please keep your question brief. Don't tell us a story, just the question. Members of the public will be able to view the live stream of this hearing on the Maryland General Assembly website and YouTube channel. And today we will hear the bills in the following order. And first, we're going to start with House Bill 196, followed by House Bill 615, followed by House Bill 291, followed by House Bill 376, followed by House Bill 363, followed by House Bill 155, followed by House Bill 107, and we will conclude with House Bill 305. Let's begin with Delegate Crosby and House Bill 196, Health Occupation Service Members, Veterans, and Military Spouses, Temporary Licensure, Certification, Registration, and Permitting. And if you have a panel, please bring your panel. Good afternoon, Delegate Crosby. Will you be so kind and get started?
Good afternoon, Madam Chair and members of the committee. For the record, Delegate Brian Crosby here to present House Bill 196, entitled Health Occupations, Service Members, Veterans, Military Spouses, Temporary Licensure, Certification, Registration, and Permitting. Just to begin, there will be a sponsor amendment, or there is a sponsor amendment, to amend the bill only to apply to spouses of active duty members. So it is very narrow in scope. And what it would do, the bill as amended, if you are a spouse of an active duty member, and that member is PCS'd, which is Permanent Change of Station, and assigned to one of our 11 military installations here in Maryland, then we automatically grant you temporary licensure for health occupations. We did something similar to this in 2020. It was House Bill 349 that year in Economic Matters, and we did this for, it was much broader actually, for every license underneath the Department of Labor. And so we're trying to do the same for individuals and families who come here to Maryland. Frankly, I experienced this while I was on active duty. Is, you're told where to go. You don't really have much of a say in that. You pretty much get about 6 months of notice, and then your family is uprooted with you and goes along, to that next duty location. And I can tell you from my own personal story and personal life. I dated somebody in. First off, I'm being filmed happily married, but at the time I was dating somebody in the Atlanta area, and if I were to stay and continue to my next duty assignment, her health occupation license wouldn't have transferred to that state. And so It is just something that I've heard countless times amongst active duty members. And then when I came here and was fortunate enough to serve with all of you, I've had many individuals from my area reach out about this very issue. And the fact that they can't get into the workforce because they have to get here, get their family situated. It's pretty much 3, 4, 5, 6 months before they can even start to think about the test. And then they have to sit for the test. And it's really a year before they're even in the labor market. In many instances, you can be reassigned a different duty location, or your spouse can be reassigned a different duty location, sometimes in 2 years. More often than not, it's 3. And so you really lose out on the ability to participate in the labor market under those conditions. And it's, as we experienced during the pandemic, there was a shortage of workers in our hospitals. I know the hospitals support the bill, and this is one group that we could get into the labor pool, has a license in a different state, and we recognize that. And I think it would be, frankly, very kind to the 29,000 active duty service members and their families if this bill were to move forward. And with that, I urge a favorable report.
Have you requested the amendment?
I have, and I apologize if it's not dropped off. I'll make sure I get it to you.
Okay, we got it. So is your amendment, and I have not seen it, is it the same as the Maryland Military Coalition Commission Officers Association have submitted written testimony favorable with amendment? Have you looked at that letter?
I have not, and I believe it is not the same amendment as theirs.
And so did the Maryland Board of Physicians. Have you looked at their amendment?
I have, and ours is different. The Maryland Board of Physicians amendment takes it from, it says if a license hasn't been issued in 12 days, then we grant them automatic licensure, which, in my opinion, it's already in Maryland. If you don't have it within 15 days, then you get the license anyway. So I don't know what that really changes. I would be more amenable to just amending physicians out. Frankly, I don't think this is going to impact as many people as we think. I mean, maybe 50 a year, maybe. And I'd be shocked if it's more than 5.
Okay. But since we have a work shortage, everyone counts. Are there any questions for the delegate? Seeing none, thank you so much for your testimony. We really appreciate it. My pleasure. Now we have the Job Opportunities Task Force, Iona Stoica. And would I also, may I have David Weber and Michael, just David Weber, please. And who would like to get started?
Good afternoon, Chair Peña-Melnick and members of the Health and Government Operations Committee, and thank you so much to Delegate Crosby for introducing this critical bill. My name is Ioana Stoica, and I'm a policy advocate for the Job Opportunities Task Force, and we work on advocating for low-income workers and for expanding job opportunities, which this bill emphatically does. Maryland is ranked 11th in the most burdensome licensing laws in the country, and it's 20th most honorously licensed state, with almost 60% of all low-income occupations requiring an occupational license. Now, a 4-year study funded by the Department of Labor found that 3 groups of individuals face the most significant barriers in relation to employment on the front of occupational licensing. And one of these groups are veterans and our military spouses. And this is the problem that this bill seeks to address. 39% of military spouses who participate in the workforce work in occupations that require licensing. These active duty spouses typically earn 27% less than their peers, in large part due to having to accept jobs that are not commensurate with their level of experience, a lot of the time due to difficulties arising from transferring their license. Too many of these spouses describe their financial situation as struggling or living paycheck to paycheck, according to a recent U.S. Chamber of Commerce study. So what this bill does is it does right by our veterans and military families, but it also would contribute to addressing the racial and gender wage gap, considering that a higher percentage of military spouses are Black and multiracial than the general population, and also considering that women constitute 90% of the active duty spouses. Also, this bill is fiscally sound because it increases the labor pool in fields facing extreme shortages, such as healthcare aides and childcare workers, and it increases the spending power of our population if these communities are able to obtain stable, higher-wage jobs that are commensurate with their qualifications. So that is why we are here and urge you to support this bill. Thank you so much.
Who's next?
Good afternoon, Madam Chair and members of the Health and Government Operations Committee. I'm David Weber, 5-year Army veteran and resident of Annapolis. I'm here representing AARP Maryland, one of the largest membership-based organizations in the state. AARP Maryland supports House Bill 196, and we thank Delegate Crosby for sponsoring this bill. You already have my written testimony, so I'll just touch on a few key points. The state of Maryland is currently experiencing a mass vacancy in the healthcare industry with a 50% increase in nursing vacancies within Maryland hospitals since 2021. As of this morning at 9 a.m., 18 counties have at least a 50% bed occupancy rate within hospitals. 6 of those counties have crossed the 90% bed occupancy threshold. In order for a healthcare professional to receive a certification to operate within the state of Maryland, they must undergo a grueling process of certification that can take over half of a year. Allowing service member spouses who already hold a certification or licensure from another state to receive an expedited temporary certification would help alleviate some of the issues we see today in the healthcare landscape. The average military family moves every 2 to 3 years. This means that individuals who have a healthcare occupation could potentially go months unemployed upon moving to Maryland. If this bill were to pass, it would permit those service members, spouses, and families who depend on a dual income to thrive within the state of Maryland rather than suffering for months while waiting on a certification. AARP believes we must honor the service and acknowledge the sacrifice of our service members and their spouses. House Bill 196 does so by providing greater economic viability to these groups, along with strengthening the healthcare system within the state. For these reasons, we respectfully request a favorable report for House Bill 196.
So I have 2 questions. They were actually for Delegate Crosby, but I did not see them, and I think he left. From Delegate Kaiser, who's home with a sick baby, and she asked, how long for a temporary license? Any of you able to answer that question?
I believe it was listed at 15 days in the bill, but I'm not obviously the expert on this.
Okay. And how long would it last?
Again, I could not answer that. I
Okay.
apologize.
6 months, okay. All right, Delegate Kaiser, 6 months, 15 days, and then 6 months. All right, Delegate Hill.
Thank you, Madam Chair. Ms. Stoika, I'm just trying to understand the reason why, for the purposes of expedited licenses of these, qualified folks who want to get into a labor force, a service member. So normally the widow or the military spouse includes someone who the service member died within a year, but we're allowing it to be a service member died within 3 years. Why 3 years? So as I'm reading it, I could be a widow for 3 years or almost 3 years and then come in and get an expedited license. Why are we expanding that definition? Why is it not sufficient to say it's for spouses or widowers a year after the death?
Yeah, let me get back to you on that. I'm not quite sure about the 3-year part. I know that when we were looking at the data, so there was a Department of Labor study that was funded in 2016 under President Obama that actually took us through 2020 that Maryland was part of. It was part of 11 state consortium study. And what they found is that active duty spouses and current military personnel are the ones facing the most barriers, but I am not quite sure about about widows. So I will definitely get back to you on that.
I don't see any other questions. Thank you both for your testimony today. We really appreciate it. Next, we have the Maryland Board of Physicians. Michael Tran. Good afternoon, sir. Will you be so kind and you can get started?
Good afternoon, Madam Chair, committee members. My name is Michael Tran, Health Policy Analyst at the Maryland Board of Physicians. The board would like to thank Delegate Crosby for sponsoring House Bill 196. The board is favorable to this bill with amendments and strongly supports the initiatives that ensure the effective and expedited licensure of military members, veterans, and military spouses. The board has a licensure goal of issuing 95% of licenses within 10 days of receiving a completed application. That goal has been consistently exceeded with an average of 99% of licenses issued within that 10-day time frame in 2019, 2020, and 2021. On top of this, military applications are already the priority of any application the board receives, which is mandated by the Veterans Full Employment Act of 2013. Military applications are the first to be processed and the first to be licensed once an application is deemed completed by staff. The board has already established multiple pathways for expedited physician licensure, including participation in the Interstate Medical Licensure Compact and licensure by endorsement. Additionally, the board has introduced online application processes and licensure by uniform application, allowing physicians to simultaneously apply for licensure in multiple states. The Federation Credentials Verification Service has also been implemented to instantly verify physician credentials. While the board supports the goals of House Bill 196, adding temporary licenses would present a significant financial burden to the board without reducing the time required to obtain a license. The board would recommend amending the bill to create more options for developing alternative processes to provide expedited licensure for military applicants. The board has heard from the bill sponsor that a proposed amendment which would replace the provision for applying to the Secretary of Health for an alternate process for the expedited licensure of military applicants in favor of provision that exempts health occupation boards from issuing a temporary license to military applicants that issue licenses within 12 business days of receiving a completed application. If this amendment is adopted, the board would change its position to favorable as well as urge the committee to submit a favorable report for House Bill 196.
Thank you. Thank you for your testimony today. So I have a clarifying question. The sponsor stated that presently is 15 days, and you're changing it to 12. Why? What's the difference? He seemed to imply that there wasn't a big difference between 12 and 15.
When the board was discussing this bill with the Senate sponsor and Delegate Crosby, we spoke of a 12-day lead time for the approving those applications, but I think through the bill drafter, they suggested 15 days.
Okay.
We are currently issuing those licenses under 10 days, so between 12 or 15 days, I don't know if that really applies to us.
Okay. All right. Are there any questions for the Board of Physicians? Delegate Johnson, I saw the light.
Thank you, Madam Chair, and thank you for coming and testifying today. My question is, if you're processing 99% of your applications within 10 days, then this wouldn't even affect you at all, is that correct?
If we were to issue temporary licenses, which this bill proposes, that would negatively impact our licensing process. We would need to require 2 more licensure staff, and issuing a temporary license would mean we're issuing 2 licenses for the same application, which means we got to process a application for the temporary license and then issue and process a license for the full licensure. So that's additional work for the same license.
Permit or a license within 10 days, would you even bother with a temporary?
The board suggests that we be exempt from the issuing of a temporary license because of that reason. We're already issuing already issuing licenses in a very quick time span, so doing this doesn't seem necessary.
That was the million-dollar question. So you're okay with being exempted?
Yes, ma'am.
And that is exactly what the sponsor suggested. Thank you so much. Great question. Delegate Chisholm.
Thank you, Madam Chair. Can you tell me what the difference is between a temporary license and the actual license? Did you say I'm just curious. You say you're processing them twice. What is the big jump from the temporary to the permanent that would take 2 extra people? That's what I'm trying to get at.
So as of right now, the board does not issue any temporary licenses. So to do that, we would have to implement a new licensure system that would require some fees and extra staff to issue those licenses. I believe in the bill it is when the military applicant submits a application for licensure and temporary license, I believe they have to be issued at the same time. So we would issue that temporary license first with all the requirements and then issue another full license.
You want to follow up? It's a freebie, no? Okay. Delegate Rosenberg.
Thank you, Madam Chair. How many temporary licenses do you expect to have to issue?
The board believes it would be a relatively small number, but I don't have an estimate that as of right now.
The case, why do you need extra personnel?
To issue the full licensure of our physicians and allied staff licenses, we currently issue, I believe, 14, and we would require extra staff to do those expedited licensures, as those would be required to be.
Even though it's only a handful?
Yes, sir.
Okay, thank you.
Okay. Any other questions? We do have someone else virtually from the Board of Physicians.
Yes, ma'am. Dr. Mark Olzik was
Yes.
signed up for virtual testimony, but he is sick today and he will not be able to do the
Okay,
testimony.
well, thank you for letting me know.
Thank you,
I
Madam Chair.
appreciate it. Seeing that I don't see any other questions, this actually concludes the bill hearing on House Bill 196. So next, we're going to move on to House Bill 615. Delegate Ampry, if you have a panel, please bring them up. Work Group on Black, Latino, Asian American, Pacific Islander, and other underrepresented behavioral health professionals, extension of dates. How are you?
I'm doing well. How you doing?
Good. I feel like we've done this before.
This is going to be the easiest bill of this committee. I'm trying to keep it easy for y'all today.
Good.
I come bearing gifts. This is the easy one.
It does not get you extra time. Just saying.
Thank you, Madam Chair, and members of the committee. This is really coming home away from home these days. It's good to be in the HGO committee. I'm here for the record, Delegate Marlon Ampry here in support of HB 615. This is really just a simple tweak amendment to the bill that you all passed last year, HB 97, the work group on Black, Latino, Asian American, Pacific Islander, and other underrepresented behavioral health professionals. We know that we have a crisis in our country in regards to behavioral health, and one of the issues that we have is the lack of people of color who are providing behavioral health services, and you all were able to pass the bill last year. I'm so thankful for that and that work. And we're just looking to extend the reporting and termination dates to 2024 and 2025, respectively. We want to make sure that this work group gets it right, number one. But number two, also understanding that we have a new administration and the Secretary of Health has a lot of responsibility with this work group and appointing members and appointing the chair. We wanted to make sure that under a new administration that they had the opportunity to be involved. And this new administration is working hard towards addressing behavioral health. So I think it's a great opportunity to ensure that we have some cohesiveness there to extend the reporting and termination date. So that's really the ask for this bill, and I hope to have a favorable report.
Are there any questions for Delegate Ampry from the committee? Delegate Bagnall?
I don't believe I've seen those amendments as of yet, so I'll have to look at them and circle back offline. Yep.
Make sure you come to the subcommittee.
Yes.
Okay. Delegate White?
Yeah. No, so we literally paused on assembling the work group because of the new administration, just because we felt as though we should wait until we have a new administration with the Secretary of Health. So we haven't done any digging on findings yet, but we have assembled our primary people that we're assembling to forward to the Secretary of Health with our suggested members that to join the work group. So no findings as of yet.
Thank you. Any other questions for Delegate Ampry? Delegate Taveras? Yeah, the light. I have to see the light. Go ahead.
I think with the additional time is more so allowing us to put this all under, because the Secretary of Health and the Department of Health is going to be spearheading this work group. It's really more about making sure that one administration gets to do it all. If we had to put together the work group under the previous administration, it would have been a clunky move over and it would have been disjointed. Also, we have a new administration that has listed out goals around supporting behavioral health. So I think it's in alignment with already their vision. So I think that just everything aligns a little bit better here to push this out a little further.
So our mics are not working very well today, so if you can speak up, that will be great, okay? Delegate White, do you have another question? Oh, no. Okay. Delegate Taveras, do you have another question? Will you turn it off, please? Thank you so much. Any other questions? Seeing none, Delegate Ampry, thank you for being here with us today. We really appreciate it, and this concludes the bill hearing on House Bill 615.
Thank you.
My pleasure. Next, we have House Bill 291, Delegates Gazzoni and Collison. Delegate Gazzoni, will you bring your panel up if you have one? Health occupations, clinical and graduate alcohol and drug counselors licensure. And good afternoon.
Good afternoon. I do have a panel member that's on video,
Okay.
on Zoom.
Wonderful.
Thank you for having me. Good afternoon, everybody. Madam Chair and rest of the members of the House and Government Operations Committee. I'm Delegate Pam Gazzoni, representing Howard County's District 13, and I'm here in support of House Bill 291. HB 291 will address Maryland's licensure requirements for drug and alcohol counselors. More specifically, the legislation will make the credentialing requirements more consistent with the requirements of other professions regulated by the Board of Professional Counselors and Therapists. The current statute requirements include, for example, that candidates have graduated from accredited regional universities. HB 291 will remove that regional requirement. With the workforce challenges being what they are, I do not believe that we want to make a graduate of an accredited program in, say, California or Nevada have to jump through additional hoops to be licensed in Maryland. Removing barriers by streamlining the licensure process for drug and alcohol counselors will help reduce administrative barriers and support the healthcare workforce without affecting quality licensing standards. HB 291 will expand the workforce pipeline and help us address the critical workforce shortages without impacting the quality of care. I respectfully request a favorable report on HB 291.
Well done. You look like a pro.
Thank you.
All right. Who's next?
Me? Okay. Hi. Good afternoon, Madam Chair and members of the committee. My name is Vicki Walters. I'm the Executive Director of Reach Health Services, a substance use disorder treatment program located in Baltimore City, and I'm also representing the Maryland Association for the Treatment of Opioid Dependence today. It's a statewide membership organization with over 68 opioid treatment program members dedicated to assuring quality care for patients in treatment for substance use disorder. We and our members provide all medications federally approved to treat opioid use disorder and offer substance use disorder, mental health counseling, along with an array of case management and peer recovery services in our facilities. We employ a wide variety of counselors, including certified addictions counselors, licensed graduate and professional counselors, and licensed graduate and professional social workers. I'm here today to testify in support of House Bill 291. The added language to the bill simply clarifies already accepted definitions of the counseling profession and higher education, and the language removed was overly specific and should not be codified, we believe. I'd like to see the Board of Professional, or we, not just me, would like to see the Board of Professional Counselors and Therapists retain the oversight and control over the educational requirements for counselors and therapists. Hopefully, this will address the severe workforce shortage in behavioral health that our state is currently experiencing. Thank you for your time today and your consideration in support of House Bill 291. I urge you to find in favor of the bill. Thank you.
Thank you for being here today. We do have two witnesses that are part of the sponsor panel. The first one is Ms. Laura Berg. Can you please unmute yourself and you can start your testimony?
Actually, I was hoping that I'm Laura Berg. I'm the Executive Director of the Board of Professional Counselors and Therapists. I was actually hoping for our chair, Mary Ann Drotliff, to be able to testify first.
I can do that for you. Hold on
Great.
1 second, please.
Thank you so much, Madam Chair.
Will you let her in, please? If you can allow Mary Drotliff. She's in?
Yes.
Yes, will you please get started with your testimony?
Yes. Good afternoon, Madam Chair.
Good afternoon.
It's a pleasure to be here with all of you today. I am Mary Drotliff, and I am chair of the Maryland Board of Professional Counselors and Therapists. I am here to express the board's support of House Bill 291, which was drafted by our members. As most of us know, there continues to be significant demand for qualified and competent alcohol and drug treatment clinicians throughout communities within the state so that we can effectively support and encourage rehabilitation, recovery, and most importantly, save lives. The purpose of this bill is to better standardize the requirements of the licensed clinical alcohol and drug counselor, excuse me, the LCADC credential, so that it is more consistent and possesses greater alignment with the other professions regulated by the board that hold the same scope of practice. The board recognizes how much the profession has matured and evolved since its inception, resulting in an incongruence with some of the current explicit statutory educational requirements of the specified course and learning prerequisites. Therefore, this has led to greater confusion and lessened efficiency in the application and licensure process. The bill's intent is to further broaden the field of applicants by both alleviating much of that current confusion around requirements for becoming a licensed clinical alcohol and drug counselor, as well as for creating greater clarity. The board very much believes that the passage of this bill will further the licensing process for those seeking the licensed clinical alcohol and drug counselor credential to be much more efficient because of the greater standardization, which continues to be an ongoing goal with all applicants who fall under our authority.
You can wrap your, are you finished?
I just have one more sentence.
Go ahead, go for it.
For all the reasons I stated, the board requests a favorable report on House Bill 291. Thank you very much.
Just stay on, do not drop off in case there are questions. And now we're going to Ms. Laura Berg.
Yes, hi, thank you again, Madam Chair.
You're welcome.
Again, I am the Executive Director of the Board of Professional Counselors and Therapists, and I endorse everything Chair Droutliff has stated, and I also am here if there are any additional questions.
Thank you. Oh, we love that testimony. It was so short. Are there any questions? This actually concludes the panel. Yes, actually, there are a lot of questions, right? Do I have questions? We have a lot of questions for you.
Thank you. I'm touched by your generosity.
We have Delegate Johnson.
Sure, and I spoke with Laura about this as well, so I have good information. Essentially, what this does by making it specific to professional counseling.
Delegate, will you be so kind and put the microphone closer to you? Yes.
Sure.
Thank you.
By making it regarding professional counseling, it makes it clearer that this is a licensure for clinical practitioners, not people who just have a background in a policy area or something along those lines. So just sort of makes it a little bit clearer and cleaner as to who they're targeting.
My pleasure. And they're working on the, thank you very much. Thank you. We appreciate it so much. Delegate Hutchinson. You're welcome.
Do you know what the original intention was, why they even said it had to be regionally and what that definition meant?
I don't know specifically why it was regional, but I do think that it had to do with sort of the early nature of this particular licensure. You're nodding, and I appreciate you nodding. Thank you. So again, I think we've come a long way. There's much more understanding about the specifics that they want to have in the education programs, and so some of it is to remove the very specific language from statutory language and allow the board to have the regulatory requirements as it does in a lot of the other similarly situated therapy categories.
and you did excellent.
Thank
I'll
you.
allow Ms. Walters, do you want to add to that?
So from my perspective, I'm a licensed clinical social worker, and I feel like this bill, thank you, Delegate Gazzoni, for introducing this bill, it more aligns the Board of Professional Counselors and Therapists with what the Board of Social Work is already doing, and I appreciate that. And I believe it will help with our workforce shortage.
Delegate Hutchinson, do you have a follow-up? All right. Are there any other questions from the committee? Seeing none, thank you very much for being with us today. Delegate Gazzoni, you did an excellent job,
Thank you,
This
Chair.
concludes the House Bill, the hearing on House Bill 291. And next, for our committee members, we have House Bill 376. It is being sponsored by our Speaker Pro Tem, Delegate Semple Hughes. Delegate Semple Hughes, you may come up with your panel, please. And it's actually titled Health Insurance Diagnostic and Supplemental Examination for Breast Cancer Cost Sharing. And you can get started. How are you?
I'm well, thank you.
Great to see you.
I know, great to be back home, right?
Yeah, the delegate used to be on this committee,
Yes.
so you're missed.
Thank you. I miss everyone as well. And the good thing about coming from this committee is that I've done my homework. I know what you like to hear and what you don't like to hear.
Thank you. That makes life so easy.
Yes, indeed. So I will go ahead and formally get started. And again, just like to say good afternoon, Chair Peña-Melnick. And, oh my, it's odd to not to see our Vice Chair, Kelly here, but nonetheless.
She's actually, and she'll be okay with me saying this, she's actually went to visit her daughter who is in college. They're having a parent reunion.
Oh.
But she worked very hard this morning and she and Delegate
Yes, she
Collison
did.
handled those questions really well and made the committee really proud. And it was the work of the committee, everyone involved. So thank you.
Yes, indeed. Always, always a pleasure for us to always work together and do our due diligence. And so to all the members here in HGO, this afternoon I present before you House Bill 376, as is entitled the Diagnostic and Supplemental Examinations for Breast Cancer. I personally have found that this subject is very important to me from many perspectives. One in particular is that I have walked into the room for the examinations and was very, very much intimidated, nervous, and kept avoiding it actually for years. It wasn't until one of my sorority sisters says, hey, you need to go ahead and get this mammogram done, and it's not as painful as you think. And so that's kind of the conversation that has been going on, in my opinion, throughout various minority communities in particular, and it's been avoided for many years by others. And so to that end, when you get to the point of having the examination and then that awaiting period of whether or not you know the results, you get the letter, and then you're just sitting there trying to figure out the next steps if one is required. What also has happened is that the financial component has led people to stay away to get the proper assessments and supplemental information that they may need to have to move to the next step. The other tidbit I'll share with you is that this bill was also introduced a few years ago, ironically, by our now Lieutenant Governor, Aruna Miller. And so this is not the first time, this is not the first step to make sure that we are moving the needle in Maryland to ensure that there isn't a financial gap in services that persons may need. So that's why I'm grateful to reintroduce this bill. To highlight a little bit additional information is that the diagnostic breast imaging is used as a follow-up test after finding an abnormality on a screening mammogram. Diagnostic imaging examinations include diagnostic mammography, breast ultrasound, and breast MRIs. A Susan G. Komen Commission study found that the average out-of-pocket cost for diagnostic imaging examinations range anywhere from $234 to $1,021. Patient advocates, in which we have all had those in our communities, they have often shared their concerns about the cost and what has led to persons not being able to afford the next step in the process and delay care. In 2023 in particular, approximately 5,760 women have been diagnosed with breast cancer, and approximately 850, unfortunately, will die from this disease. When I opened, I referenced that I've done my homework. I want to share that this bill was on the table of being introduced last year, but I know that in the state of Maryland, we have a process to go through the Maryland Healthcare Commission. And in doing so, I wanted to get an idea of what it would cost, what the impact would be on the consumers of the state of Maryland should we allow this particular diagnostic and evaluation screening to occur and then affect insurance providers. The estimated yearly cost is about 83 cents per year to privately insured healthcare premiums. That information, again, was studied and it was provided to me early on last year, February of 2022, so we could walk into this request, this ask, with knowing what the information is and how it would impact our state and our consumers. So I believe you have that information before you, and I would like for you to certainly take the time to look at that, but that's one step in our process. And in closing, I'll just highlight that this tool and this piece of legislation does not cover everyone, meaning that this is one step to ensure and be inclusive of many, but if we still have persons who are paying high deductibles. And with that being said, we have made it a point to speak with the federal delegation to have this extra diagnostic process to be a part of the list that is already automatically approved, and you're not having to do additional out-of-pocket costs. So again, you may hear from constituents that say, this doesn't help me. Well, you know, and honestly, truly, it cannot at this juncture, but this is one step in our process to getting to that goal. So today I'm asking for your favorable support on this piece of legislation, House Bill 376, so we can continually work together in the state of Maryland to combat the disease. And thank you, Madam Chair, and I have a panel here to expound upon the information as well.
Who would you like the next person to be?
It'd be Ms. Massanoni.
Good afternoon.
Good afternoon. Thank you so much for having me. Good afternoon, Chairwoman Pena-Melnick and members of the Health and Government Operations Committee. Thank you for the opportunity to provide testimony in support of House Bill 376. My name is Jenna Massanoni. I work with Cornerstone Government Affairs, and I'm here representing our client, Susan G. Komen. As Delegate Sample Hughes mentioned, the MHCC Commission study, which is in my written testimony, if you're looking for it, it is there, showing that 83 cents per year to privately insured healthcare premiums. It's also important that you know that this bill has passed in 9 other states, and the fiscal notes from those states have shown insignificant impacts on premiums. We greatly respect the work of Maryland's private health insurers, and we spoke with each private insurer during the interim. This bill addresses cost-sharing requirements for health plans that already provide coverage, screening, and diagnostic services. This just ensures that patients who need this follow-up for medically necessary reasons don't forego the test due to unaffordable out-of-pocket costs. For those who may think this bill is not necessary, I'll share the unfortunate statistic that breast cancer is one of the most diagnosed cancers in Maryland, and in fact, Maryland has ranked among the top states in breast cancer mortality. I would go further to say that it's really necessary to address this at the stateside level until it's passed by Congress by Komen's legislation that has been introduced federally. Unfortunately, we all know someone with breast cancer, or perhaps you've experienced it yourself. Susan G. Komen is fighting for the cure, and they'll get there one day, but in the meantime, this is one thing that I think that we can do. Thank you for your time, and we would request a favorable report for House Bill 376.
Who's next?
Good afternoon, Chairwoman Pena-Melnick, Vice Chairwoman Kelly, and members of the House Health and Government Operations Committee. Thank you for the opportunity to provide testimony in support of House Bill 376. My name is Rebecca Glick, and I am the Maryland State Policy Manager for Susan G. Komen, the world's leading nonprofit breast cancer organization. Currently, individuals have access to preventative screening mammography under the ACA. However, if a mass is detected, the next step is for them to receive a diagnostic exam, such as a mammogram, breast ultrasound, or breast MRI. A 2019 Komen study found that diagnostic imaging, as Delegate Sample Hughes noted, costs typically between $200 to $1,100, which leads many women to forego diagnostic testing because they simply can't afford it. This bill, which has passed in 9 other states, including Texas and Louisiana, would remove costs as a barrier for diagnostic imaging. Early detection is absolutely critical in reducing the risk of death from this disease. The earlier we can diagnose breast cancer, the more treatment options we can provide to patients. We also know nationally that Black women are typically diagnosed at a later stage in their cancer and are about 40% more likely to die from the disease than white women. This legislation would also help breast cancer survivors and those with a family history of breast cancer. If you're a breast cancer survivor or have genetic risks, the follow-up testing you receive for the rest of your life to monitor the disease will be coded as diagnostic. Our intent with this bill is to save lives and costs for patients and the healthcare system. It is much more expensive for health insurance companies to treat metastatic cancer that has spread to the lungs, bones, or liver, for example, than it is for a stage 1 breast cancer diagnosis caught early through medically necessary diagnostic imaging exams. Our hope with this bill is to save lives and reduce healthcare costs while addressing health equity for breast cancer patients. I strongly urge you to provide a favorable report on House Bill 376. Thank you.
Who's next?
Good afternoon, Chairman Pena-Milnick and delegates. My name is Renee Williams-White. On July 6, 2022, I was diagnosed with breast cancer. Prior to my diagnosis, I had to pay approximately $900 for a diagnostic mammogram. In addition, I had to pay $900 for an ultrasound. I'm thankful that I had the resources to pay for my tests. During my recovery journey from surgery to radiation, which ended in December of 2022, I began thinking about residents in the state that may not have the resources to pay out-of-pocket expenses. No resident of our great state should have to choose not to have a diagnostic mammogram due to the cost. House Bill 376 will ensure that many Maryland residents, women and men who are impacted by breast cancer, will not have to choose financial obligations over health. Thank you for your time and your support of House Bill 376.
Thank you. We have a virtual witness that is part of this panel as well, and that is Lisa Schlagler. Let's just give it a second until we see her, and then we'll open it up. Good afternoon. How are you?
Yes, good afternoon. Thank you for the opportunity. Just a moment, let me pull this up here. So thank you. My name is Lisa Schlager, and while I serve in a professional capacity for the organization Force, I'm here today to share my personal story. In 1999, at the age of 32, I learned that I carry an inherited BRCA1 genetic mutation that significantly increases my risk of breast and ovarian and other cancers. And while scary, I feel blessed that I have this information. You see, for 3 generations before me, at least, every woman on my father's side of the family was diagnosed with breast or ovarian cancer. My grandmother and my great-grandmother succumbed to this disease at young ages, while my aunt was really fortunate to be diagnosed early and to learn of her genetic mutation. I am the first in my generation that has an explanation for these cancers, and to have the power to be proactive with my health in order to catch cancer earlier or to prevent it altogether. Upon learning of my mutation, I was referred to a number of specialists to help me manage my risk. Hereditary cancers frequently occur earlier at younger ages, so medical guidelines recommend that women like me undergo more intensive, more frequent screenings starting at younger ages. BRCA mutation carriers are advised to start annual breast mammograms at the age of 25, alternating with mammograms every 6 months starting at age 30. Unfortunately, most health insurers do not view this as essential care. Over the years, my annual cost for screenings ranged from $100 to nearly $3,000 out of pocket every year, depending on my insurance. And we're fortunate, we have great insurance. And my husband and I were able to shoulder these costs, but every day I hear from people who can't afford the recommended scans. And sadly, these are often the ones who end up being diagnosed with more advanced disease. If I had learned about my mutation when I was younger and less financially stable, I would have been in the same position. Screenings for women at average risk of breast cancer are covered at 100%. We need to do more for the women in our state who are at increased risk. Ultimately, this will save lives and money by detecting cancers earlier when they are easier and less expensive to treat. Thank you.
Thank you for being with us. There is also a Claire Dorothy. If you can come up. And also Lisa Peabody. Renee Williams, you testify already. Yeah. Can you get started, please?
Yes. Thank you so much. Thank you, Chairwoman Pena-Melnick, and honorable delegates. My name is Claire Doherty, and I'm the CEO of the Brem Foundation to Defeat Breast Cancer. The Brem Foundation is an organization devoted entirely to advancing early detection of breast cancer. Created 17 years ago by Dr. Rachel Brem, Director of Breast Imaging and Intervention and Professor of Radiology at the George Washington University Medical Center, and herself a breast cancer survivor, as well as some amazing women from Calvert County. The Brem Foundation maximizes every woman's chance of finding early breast cancer through education, access programs, and advocacy. We fight for every woman to have access to the screening and diagnostics she needs, regardless of her ability to pay. I'm here today to offer the Brem Foundation's strong support for House Bill 376, which increases access to life-saving diagnostic and supplemental breast imaging by eliminating patient cost sharing. Last fall, Katie Couric dropped a bombshell when she widely shared her breast cancer diagnosis with the world. With her announcement, Couric put a spotlight on breast density, as well as the fact that many women require breast exams in addition to mammograms, such as ultrasounds and MRI, to either diagnose or rule out a breast cancer diagnosis. In fact, thousands of women each year learn that they require screenings beyond mammography. The harsh reality, though, is that these tests are out of reach for many women, sometimes referred to as the hidden costs of breast cancer diagnosis. Like the woman who, like Lisa, who testified before me, I had to pay $1,000 out of pocket for a breast MRI back in 2016. And while I was able to shoulder those costs, for many women that has a chilling effect, and they simply did not continue to pursue their diagnosis. I think that's, my time's up. Thank you for considering this legislation. It will save many lives. Thank you.
Thank you for the work you do, and say hello to Dr. Brem.
I will.
Good afternoon.
Good afternoon. My name is Lisa Peabody, and I'm a Maryland constituent and also the advocacy manager at FORCE. You heard testimony earlier from Lisa Schlager from FORCE. FORCE is a national nonprofit, and our focus is on constituents who carry a genetic mutation or have a strong family history of cancer, and we support those patients. Through screening at earlier ages, this is a high-risk group, and they have the opportunity to find precancerous or cancerous cells earlier through these screenings when they're less expensive and easier to treat. And this is why we truly need your support of HB 376. Breast cancer is the most common cancer in Maryland women. It accounts for 30% of all new female cancers, and it is second only to lung cancer in related deaths. We really need to care for the women and the people in our state. As we've heard before, people have this BRCA1 mutation. That's the popular one that people have heard of, and it contributes to a 70% lifetime risk of breast cancer, really high risk. And medical guidelines recommend that individuals with BRCA1 start screening at age 25. And so imagine having this cost of this MRI when you're 25. It's just not, it's not affordable. The screening also needs to be more intensive and more often, and you're excluding this group of people from accessing this care with these high costs. Often, the services are applied to a person's deductible or denied altogether through their insurance company, and patients are faced with a dilemma, as we've been hearing: forgo the expert-recommended screenings or take on the cost of that test. And unfortunately, these screenings are just unaffordable for so many.
This financial inequity contributes to health disparities in Maryland. Those who lack financial stability simply can't afford the recommended interventions. About 10% of the population carries an inherited genetic mutation that increases their risk of some cancers. And we must ensure that these Marylanders have access to the service they need. We encourage you to endorse HB 376. Thank you.
Excellent timing. Thank you. Are there any questions for the sponsor and her panel? Delegate Hill.
Thank you, Madam Chair, and thank you, Madam Speaker Pro Tem, and all of your panelists. I just want to be clear. The group that's not covered by this bill are the uninsured. So they're still going to have to find the money to pay for these tests unless, right? So are there ways that the uninsured are having their tests through grants or programs? Can anybody speak to what we do for people who are uninsured?
Who will be the best person to do that?
She's going to speak specifically about that particular group that they help.
I can speak to that, yes. Thank you so much for your question, Delegate. The Brehm Foundation runs something called, our flagship program is the B Fund, where we grant out locally to providers to cover the cost of screening beyond mammography, as well as diagnostics for uninsured or underinsured women. We have reached thousands of women in Maryland and across the area. That said, we should not have to be, resorting to this sort of coverage through a foundation, whereas we think through a public policy change, we would be able to touch many women. In October, I met a woman named Belsi from Guatemala. She was uninsured. She had no job, and she had found a lump in her breast. And she went to a local provider, Mary Center, and the Brehm Foundation partners with them. And because of the Brehm Foundation, we were able to cover all of her screening and diagnostics as well as all of her rides to the clinic. There are many women like Belsi out there, and I think this legislation will go part of the way to helping them, but again, won't, I think, cover every woman in need. Thank you.
Delegate Bagnall.
Thank you, Madam Chair, and thank you to the sponsor and to the panel for this bill. My question is, does this bill also help the people who are in that pool that comes back without a declaration after the initial mammogram, where if they, for instance, they have dense breasts and they, there's no information from the initial mammogram, and it requires those supplemental diagnostics or those supplemental examinations.
For the question, yeah, I just wanted to reiterate that even more so, simply because we have persons who have the inheritance of their family history of this being an issue, and so yes, it would very well cover them. And then I also had put in my testimony is that it's important to look at that, because as we get more and more into at the doctor's appointments of asking the family history and understanding what the risks are of some of the things that they're encountering in their environment, it very well addresses that as well. So it was important to make sure that was a part of the conversation and a part of the legislation.
Okay.
Thank you.
Thank you. I don't see any other questions. Seeing no other questions, thank you very much for your testimony today. We really appreciate it, and this concludes the bill hearing on House Bill 376. Thank you very much. Have a blessed day, everyone. Next, we have House Bill 363. Delegate Collison, will you be so kind and bring your panel? Maryland Health Benefit Exchange and Maryland Department of Health Care Coverage for Undocumented Immigrants Report.
Thank you, Madam Chair, and good afternoon, colleagues. And Madam Chair, I also want to thank, in advance, want to thank you for your flexibility and accommodation, because we do have testimony today from someone who will be speaking Spanish through an interpreter. So I absolutely appreciate your indulgence. Thank you for giving me the opportunity to present HB 363 to you today, which we've entitled the Health Benefit Exchange in Maryland Department of Health, Healthcare Coverage for Undocumented Immigrants Report. And that's really important, because what this bill does is it asks those two entities, which frankly are two of our strongest and most and organized entities, to really take a look at how we as Maryland could begin to cover all Marylanders. And I want to put an emphasis on the Marylander part of it, because we are talking about our neighbors, our friends, the people who are serving us, the people who are working in Maryland, who are paying taxes in Maryland, but currently don't have access to the benefits of the taxes they are paying. So the question that we are asking of the two agencies is, what would we need to do, and how much would it cost to provide access to everyone, including and particularly undocumented immigrants, to programs like the Children's Health Care Program, to our health care exchange, to our to Medicaid? What would we need to do? Let's take a deep dive into what should happen. You know, I've heard numerous stories. There are many folks in my district that are affected by not having health care coverage because they can't get it. It affects their ability to work. It affects their ability to provide for their families. You know, providing health care is just the right thing to do. So, you know, I'm going to start with that. But it's also in the best interest of the state, because we want to reduce the cost of uncompensated care. And because we're compassionate humans, we require our emergency departments to take everyone, and that is the most expensive health care in the state and probably in the country. And yet it's the only access to health care that people without insurance have when they need it. So allowing people to get health insurance that will provide preventive care, urgent care when it's needed, you know, a sore throat that can be treated in the short term, doesn't need, you know, a $5,000 visit to the emergency room, as long as that person has health care. Last year, we demonstrated our commitment, our strong commitment to families by passing the Healthy Babies Act. You know, that bill expanded our Medicaid coverage to pregnant women and babies who are undocumented. And it dramatically increases the survival rates for moms and babies. It was a big win for immigrant moms and their families, but now we need to look at the whole family. This bill attempts to do that by asking our agencies to look into ways that will compare options, look at the different options that we have, and which are the ones that we could adapt in order to meet the needs of all Marylanders. I think you'll see some information in the packet. One individual said we need to make sure that these agencies, when they do their report, are reflecting benefits that are equal to the benefits that I receive or that you receive. And I would be committed to that. I think you'll also hear that there's a recommendation that we, specifically include dental coverage That will come as, it will come as no surprise to those of you who know me and were in this legislature last year when we passed Medicaid coverage for all adults. I value dental care very highly and definitely want to see it included in this study. So given that, I'm asking you to think about our commitment to all Marylanders to make sure that our health system is sound and have our two of our strongest entities look and consider what our options are to provide that. So I really thank you for your consideration of HB 363, and I respectfully ask for your favorable support. And I'm not sure who wants to go after me.
Who would you like to go next? Go ahead.
Chair Pena-Melnick and members of the Health and Government Operations Committee, thank you for this opportunity to testify in favor of House Bill 363. I'm Stephanie Clapper, Deputy Director of the Maryland Healthcare for All Coalition. As Delegate Cullison said, your committee has made great progress towards health equity already through passage of legislation like the Healthy Babies Equity Act, also the Health Equity Resource Communities Act. And I'm here today to testify on behalf of the over 300 faith, business, labor, community, and healthcare organizations that make up the Maryland Healthcare for All Coalition, and all stand in support of expanding access to quality, affordable healthcare for all Marylanders. And I do mean all, regardless of immigration status. It is a tragedy that so many of our friends and neighbors are precluded from accessing the health care that they need simply because of their immigration status. And House Bill 363 would be a good step forward so that we can get the information that we need in order to see how Maryland can move forward and make this a reality. This is a matter of health equity. There are disparities in access to coverage for Black and Latino Marylanders especially. They are sicker, hospitalized more frequently, and die younger. Creating this report will help Maryland in its efforts to figure out how we can improve access to primary care and management of chronic conditions for these populations. In addition to this being a matter of justice, as Delegate Cullison said, this would help all Marylanders by reducing the uncompensated care costs that go through our hospital systems and that all Marylanders end up paying in the end. Thanks to your leadership, Maryland has one of the top 5 healthcare systems in the entire nation, but we need to figure out how we can make it accessible to all Marylanders, not just some. I urge a favorable report on House Bill 363. Thank you for your consideration.
Thank you for your work. Who's next?
Chair Pena-Melnick, members of the committee. My name is Dr. Michelle LaRue, and I'm the Director of Health and Human Services at CASA, Maryland's largest immigrant organization. CASA asked the committee for a favorable report on House Bill 363. This legislation represents an important milestone in our journey towards creating a resilient healthcare system for all, especially communities of color who have been disproportionately impacted by lack of care. We thank Delegate Cullison and the chairwoman for their leadership in this bill. The majority of families who enter our doors at CASA are undocumented and uninsured. We work tirelessly to ensure the immigrant community is receiving the care they need, but sadly our services are in very high demand as our community is entirely ineligible for coverage and must rely on overwhelmed safety net providers for care. Maryland has done great strides in prioritizing health equity and been a leader in embracing reform. Yet little has been done to address the access for care for the nearly 5% of the population that remain undocumented and uninsured. In 2022, this committee took a bold step in passing the Healthy Babies Equity Act, as was previously mentioned, that grants access to care by expanding Medicaid for those who meet the normal requirements for the program regardless of immigration status. But the work is not done. Nearly 200,000 Marylanders still don't have access to health care simply because of their immigration status. House Bill 363 seeks to gather information to help us better serve our uninsured residents by comparing options of offering affordable health care coverage to state residents who are ineligible for the Maryland Medical Assistance Program, Children's Health Program, or qualified health plans through the Maryland Health Benefit Exchange due to their immigration status. This study is a crucial step in ensuring that we have the necessary data for the coverage for the community that is in most need. This common sense legislation is uncontentious and aligns Maryland with its values for protecting our communities, treating all people with dignity, respect, and care. CASA urges the committee to provide a favorable report on House Bill 363. Thank you.
Excellent timing. Who can follow that?
Good afternoon, Delegate. My name is Cristina Riveras. I am here to share with you my testimony of how hard it's been for me in my community to go without health insurance and why it's so important for this study to be happening. I am documented and I'm insured. I live in Hyattsville and Prince George's County with my family of 4 children, and every day I face the burden of living life without access to health care. I have many health problems, but without health insurance, I can't get any of them addressing. The recovery I have from my giving birth to my daughter last year, my vision problem, my dental problem is my back pain. I have been able to go to the doctor at all, with my back. I can work, and my husband is the only who isn't provide for our family. He doesn't have health insurance either. With his income, we cannot afford to buy a private insurance. We need access to Medicaid and affordable insurance. There are clinics for our community, but we can't make an appointment at clinic. The first thing they tell us is without insurance, your first appointment will be $200 or more, and don't go to the hospital because the price even is more. We don't get treatment because we don't have access to health insurance. Please imagine how difficult it is to be like this, and hurt me just thinking that something worse could happen to us because of eye illness we don't know we have without checked out. All my children need to because they are all small and depend on us. Likely because they are born here, they are eligible to for care. And what if something happening to me and or their father? One of my daughters is only 4 months, and the other has Down syndrome. This bill is going to require to the state to report of people like my family too. So we are start making sure my community has health insurance. We need to have this possible to see a doctor. Thank you for taking care of our need. Please pass this bill. Thank you.
Good afternoon, Madam Chair and members of the committee.
1 second, she's going to put it on.
Here we go. Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor, and I'm here on behalf of Kaiser Permanente. Kaiser Permanente partners closely with CASA as a safety net provider for undocumented Marylanders. We provide about $35 million a year in charitable coverage and charitable care to this population. And we continue to be really committed to serving that population. I think this study is really important to look at what other options are out there. It wouldn't in no way decrease our our commitment, but would help potentially expand the number of folks we're able to serve. And we look forward to continuing to work with CASA, through our charitable care program, through Medicaid, through the exchange, whatever is in the best interest. So urge a favorable report.
Thank you. Yes, wait a second. We're having a little, go ahead. It's on.
Oh, there we go. So our other speaker wasn't able to make it, so I think this is our panel.
Vincent DeMarco.
Oh.
Okay,
Yeah,
for him, okay.
right.
All right, sounds good. So are there any questions, thank you so much, for the panel? Delegate Morgan?
Madam Chair.
My pleasure.
As far as I'm aware of, an undocumented immigrant is able to buy private insurance. This bill is to study for really what would affect Medicaid, the CHIP program, and pretty much for low-income free healthcare. My question is, does anything in this study or the report do have it tied to anything that would tell us the results of offering these free programs and how much more undocumented immigrants may come to the state of Maryland because we're offering these free benefits?
Thank you, Delegate, for that question. There's no way of absolutely knowing that, of course. But what I was stressing was these are folks who are here in Maryland. They've been living in Maryland. They've been paying taxes. And the interesting thing about undocumented immigrants who pay taxes, if they don't get refunded. So if they paid more taxes than into Maryland, into the state of Maryland, than they were supposed to, they don't get that refund. So and those are the things that it's taxes that are paying for these public services that we provide. And they are providing public services to us because they are many times in the service industries, which is why they can't afford public or private insurance. So this bill opens opportunities and looks at options. Some of the programs on our healthcare exchange are some of the lowest cost programs in the country. I'll be talking about that bill next week. But so this bill says, what would it cost the state? You know, I mean, I think we could find, when we look at this in real time, the cost that we have now for uncompensated care will be reduced, even if we do provide some state funding, public funding for their health care.
Subcommittee. Thank you, Madam Chair.
My pleasure. Are there any questions, Delegate Taveras?
Thank you, Madam Chair. Y gracias a todos ustedes por estar aquí hoy con nosotros. Delegate Cullison, I too commissioned a study that just was released this month, and I just want to bring a note to the floor on that, and I'm reading it directly. It says that in 2019 alone, immigrant households earned more than $6.9 billion and paid more than $1.8 billion in taxes, and that's just in the state here, and including $723 million in the state and local taxes. In total, immigrant households held almost $5.1 billion in spending power and were responsible for almost $11.9 billion in Prince George's County in the GDP. So on that note, my ask is why I see some of the commentary with regards to the inclusion of dental and vision as favorable with amendments. Can we not also include these other options to make sure that we're providing a holistic service to these individuals that are contributing so heavily to our state? Thank you.
Delegate, if I'm understanding your question is, are we open to accepting amendments that would include dental and vision? Yes, ma'am. We're definitely open to discussing those, yes.
Okay. Are there any other questions? And I saw the fiscal note. In the fiscal note, it actually says it can be done with existing resources, correct?
Yes, Madam Chair. That's the study itself can be done with existing resources.
So revenues are not affected?
Correct.
Okay, thank you. Any other questions? Seeing none, thank you so much for your testimony today. Really appreciate it.
Thank you, Madam Chair.
My pleasure. We do have Kenneth Phelps. I'm going to call several people in the interest of making things flow a little better. Kenneth Phelps, Lee Hudson. Robin Elliott and Monica Guerrero Vasquez. Will you be so kind and come up? Can you get started, please?
Yes, ma'am. Thank you. Madam Chair, thank you. Members of the committee. My name is Ken Phelps. I'm here on behalf of the Diocese of Maryland. And since I'm here to give the church's perspective, I want to begin by sharing something about Christianity. And that is that it isn't about Jesus. It isn't about believing he did this or that or what our doctrines try to convince us he might have meant. It's about what he taught and how he lived. And what he taught and lived out for us is a better way of engaging with the world, a better way of being with each other, a new way to be human, a way to experience the ultimate expression of love that we name God. One of his central themes was hospitality. Hospital is in that word. It's a value we share with Islam and with Judaism. How we care for the stranger in our midst is the highest priority. It was so important that when Jesus told a story about what the Last Judgment might be like, it's not individuals who line up to be judged about this lie they told or cheating on their taxes. It's the nations who line up, and they are judged on how well they cared for the marginalized, including and especially the stranger, the immigrant in their midst who needed care. Here's another secret about Christianity. We talk a lot about eternal life. Hey, I'm preaching here. The better translation of that word eternal is authentic. Authentic life, being real human beings like Jesus, compassionate, empathetic, less fearful, and living as authentic humans is how we bring about the kingdom of heaven, the kingdom of love, the culture of love, the beloved community. With this bill, what an opportunity you have. You've got the chance to help us be a little more authentic and move us closer to our best destiny. You can help define us as a people in a new, more compassionate way. And on behalf of the Diocese of Maryland, we urge a favorable report. I thank you, God bless, and I'll see you again real soon.
Thank you. Next, please.
Yes, Madam Chair, members of the committee, thank you for hearing our testimony. I'm from the Evangelical Lutheran Church in America. We're across the state of Maryland from Red House to Ocean City. And I thank you especially for putting me on the panel with my colleague, my brother, Father Ken Phelps, who did most of my work for me just a moment ago.
Can you give us your name?
I'm sorry?
Your name.
My name is Lee Hudson. I'm
Okay,
sorry.
wonderful.
So we, as a national organization and here in the state, are on record for doing a lot of what Father Phelps talked about, which is adequate and appropriate health care for all people. And so House Bill 363 is an opportunity. I think we already know the need. You've heard in several of the bills you are considering today about the need. This is an opportunity for us to have a public discourse with real information for how we can get to that goal of covering more of the people in the state of Maryland who should be covered for all the reasons you are hearing today. Thank you.
Thank you. Next, please. Actually, leave it alone. Thank you. And look, it came out for you. Just leave it alone. If you don't touch it, it's a little bit today, it's a little fickle. It's having some issues, like some of us, myself today. Just kidding. Go ahead.
Oh my gosh, Robin Elliott, and I've been here for a long time, so I should know better about the microphone. Thank you.
It's okay, Robin.
So I'm here this afternoon representing the Maryland Dental Action Coalition. We did bring to Delegate Cullison, who was our wonderful bill sponsor with the Medicaid adult dental bill last year, just the technical issue that qualified health plans do not encompass standalone dental plans offered on the exchange. So we hope that is a friendly amendment. We think it probably is. And we look forward to working with the committee on this issue. It's really just so important to continue our work to close those gaps where people who live and work in Maryland deserve and need and it's, I think, our state's responsibility to really look at the options in order for them to have basic healthcare coverage, including dental. Thank you.
Thank you. Monica Guerrero Vasquez.
Hi, everyone. Monica Guerrero Vasquez is not able to be here today, so I am filling in for her.
Actually, we do not allow that.
Okay.
And I apologize because what would happen is that staff will have to take the whole list and redo it and all the testimony later on, and they end up staying here for hours. But I do promise you this, if you leave your testimony, your written testimony, I'll make sure that the entire committee gets it. The testimony that is written, we consider it is as important as the testimony that you give in person, okay?
Excellent.
So I noted that Centro Sol is here, and I know you do great work in the immigrant community, okay?
Absolutely.
I just have to stick by the rules.
No worries. I understand.
Thank you.
Yeah.
They apply to me as well. And are there any questions? Delegate Chisholm, and then Delegate Woods.
Thank you, Madam Chair. And my question is for the clergy. I want to make sure, because I've been a Christian all my life and my faith is deep, that I fully understand what you said, that we will be judged as a nation and not as individuals. And I ask that because there's so many undocumented people here who are good, loving people. But they've left evil nations, El Salvador, Venezuela, parts of Mexico. Am I to draw from what you said that those nations, everybody there is then condemned to hell? Because that's what you're putting on us, saying if we don't vote for something like this, whether we like it or not, we as a nation are all going to hell, and Jesus won't see us, or our Maker won't see us as individuals. I want to make sure that I understood that you clarify the statement you made.
Yeah, I'd be happy to do that.
1 second, can you, may I ask you to, and again, this is a respectful committee, so you have the question, if you can just answer it if you're able to. Otherwise, you can give us the answer offline as well.
Well, I'd be happy that this is a whole course in theology. I would just start by saying that, again, Jesus taught, we love our enemies, do good to those who hate us, so that no one is seen as consigned to, heaven or hell. And this is the church, and I'm speaking, for our theology, that, we believe that all are embraced in God's, in the breadth of God's love, and there is no distinction that we make. So when we talk about coming from evil, that's in the eye of the beholder. Stick around for the next my next testimony. I'll talk about our corporate sin, but it's judgment. It's Help me out here, Lee.
No, you can go ahead.
I don't know how to condense this into 30 seconds, Madam Chair.
Okay. Well, can you give it to us offline?
Yes, I can be happy
thank
to do
you.
that.
Don't worry about that.
Do you want me to do that as well?
Offline. Thank you.
Thank you, Madam Chair.
My pleasure. Delegate Woods, and then Delegate Banderi.
I'll be back.
My question also is for Father Phelps.
And 1 second, when you send it to the entire committee, please. Thank you. Go
I
ahead.
believe, and please clarify and help me to understand, that in essence what you are saying is that as humankind, it is both our responsibility to be both human and kind. Is that correct?
Yes. And I would say to better, as I'm thinking about this, because I've never had a question back after testifying, I don't know how many years here, and it's great to be in a conversation like this. I think of the prophets, they would talk about God's judgment, but it wasn't God's judgment. The troubles that befell, ancient Israel, as you look at the prophets in those stories, they would tell them, if you keep acting this way, if you're doing this, it's going to be your downfall. And it wasn't God's judgment or God's wrath, it was their own. Okay, we want to live this way. We want to worship the dollar. We want to do this, do that. We want to cheat. We want to, be unkind to widows and orphans. It's going to come back to bite you. And that's the judgment. And, when it all collapses, we have no one else but ourselves to blame for the way that we treated each other.
Delegate Bandari.
Thank you, Madam Chair. If I understood this bill correctly, this bill would mandate the Maryland Health Benefit Exchange and Maryland Department of Health to create just a report that evaluates different options for providing affordable healthcare coverage to state residents who cannot access the Maryland Medical Assistant Program and Maryland Children Health Program and qualified health plan due to their immigration status. If I understood it correctly, that, is that correct?
All right. Any other questions? All right, seeing none, thank you so much for your testimony. I appreciate it. We have 2 virtual testimony for the committee. If you will be so kind and just hold tightly while they come up. We have Zachary Berger and Shannon Riley. One second. Is this new virtual world we're in, right? Ms. Riley, will you be so kind and get started, please? We've been waiting for you anxiously.
Oh, I'm so sorry.
No, just kidding. It's on us, not on you. Go ahead.
I've been watching. Okay, good. Let me
Go
get
ahead,
going.
go ahead.
Everybody's busy. Good afternoon, Madam Chair, and also members of the committee. My name is Shannon Riley. I've been a registered nurse for over 20 years now, and I'm currently the population health nurse at Healthcare for the Homeless in Baltimore. Thank you so much for having me testify today in support of HB 363. Last year, I testified on behalf of the Healthy Babies Equity Act to expand Medicaid coverage for people who are pregnant postpartum, regardless of their immigration status. This body made incredible strides passing that legislation, and it is time to take the next step, exploring Medicaid coverage for all people, regardless of their immigration status. Our federally qualified health center serves those without insurance and can provide a bit of a safety net for primary care purposes, but we frequently have to refer out for specialty services. When we do that, those who are not insured face many challenges, and they're so challenging that it often precludes their ability to even complete their referrals. And this is going to be things like, a ton of paperwork, proof of eligibility for it, travel, expense, time off work, to try to squeeze into like limited appointment availability and things like that. So they really are at a true disadvantage, even where charity care exists. Once I was speaking with an immigrant without legal status about colorectal cancer screening. He said, okay, but if I found out I had cancer, what am I supposed to do with that information? I don't have insurance and I have to work for my family. He would rather not be armed with the information that he has cancer because without insurance, he has little hope for meaningful intervention that would save his life and would continue to allow him to protect his family. Tragically, he and many of our clients that we see would be eligible for Medicaid, but for their immigration status, and would never have to endure this type of inefficient and non-existent treatment. We at Healthcare for the Homeless are in support of this bill, as we believe healthcare is a human right and that no one should become sick or die related to their economic or immigrant status. House Bill 363 is a great first step to cure this injustice, and we urge a favorable report. Thank you.
Thank you. Excellent testimony. Is there are there any questions for this witness? Seeing none, thank you for being with us and thank you for being patient. We do have Zachary Berger, but I understand that he's not on the link. And that is correct, right? So therefore, this actually concludes the bill hearing on House Bill 363. I want to thank all of those that came. Thank you for your advocacy. We next have House Bill 155, Delegate Kipke. And will you be so kind and bring your panel? Genetic testing, prohibitions on disability, life and long-term care insurance, and educational materials, Genetic Testing Protection Act of 2023.
Thank you, Madam Chairman, fellow members of committee. It's great to present this first bill of the season for me. House Bill 155 seeks to eliminate an area of discrimination against individuals in our state. At the federal level, the Genetic Information Non-Discrimination Act passed 15 years ago to prevent health insurers and employers from discriminating against an individual based on their genetic information. Unfortunately, this legislation did not extend to three types of insurance: life, long-term care, or disability. It's time for Maryland to prohibit these insurers from canceling, limiting, increasing the premium, or denying coverage based on genetic information. And as you know, genetic tests are increasing in popularity and are more and more readily used in determining health status. The intent for this legislation is to avoid discrimination that patients with familial diseases and cancers have experienced. Genetic tests are helpful information for parents as they make life decisions, including securing a life insurance policy for themselves and their families. They should not be treated differently, discriminated against, or delayed receiving a genetic test because of fear that that might limit their access to insurance, be denied, or have rates increased due to their genetics. Several other states have passed legislation with individual legislation that addresses these types of insurances one at a time: life insurance, disability, and long-term care insurance. For comparison to our bill, in 2020, Florida passed House Bill 1189, which prohibited life insurance and long-term care insurers from discriminating an individual based on genetic tests. We have not seen adverse effects on insurance premiums due to the passage of that legislation. In fact, in Maryland, a bill was passed in 2008, House Bill 29, that prevented long-term care insurers from discriminating against patients who receive genetic tests, a law that's on the books to this day. I want to mention that the Maryland Insurance Administration did identify some technical issues with the bill, which in the testimony provided, there's a reprint and an amendment that addresses those concerns, and I emailed that to Council. We thank you for your time and ask you for a favorable report of House Bill 155. Thank you.
Thank you, Delegate Kipke. Excellent testimony. Who would like to go next?
So good afternoon, Chairwoman Peña-Melnick again, and members of the Health and Government Operations Committee. Thanks for the opportunity to provide testimony in support of House Bill 155. My name is Jenna Massoni. I work with Cornerstone Government Affairs, and I'm here representing ALS Association. Our intention of this legislation is to avoid discrimination from insurers. To break this down, if an individual wanted to receive a genetic test but knew it would put them at risk to either be ineligible or to have a higher premium when applying for life or disability insurance, many are choosing to forgo the genetic test. Instead of having this helpful information of being aware of their genetics and possible outcomes for their future health, people are choosing to hold off, getting their life or disability insurance first, if timing is appropriate, and then receiving their genetic test. Unfortunately, not everyone has the luxury of time, and we don't see that process as a logical solution. It's also important to remember that a genetic marker does not always progress to a disease. Genetic tests reveal probabilities and not certainties. Regardless of the outcome of a test, individuals have the right to know, and they should not be treated differently due to their genetics. As an amendment, we have stated that this bill does not prevent a long-term care, life, or disability insurer from accessing an individual's medical record as part of an application exam. And we also have an amendment to update the 2008 House Bill 29 Insurance Code 18-120 to ensure that that code reflects the provisions of this legislation. For those who are concerned that this legislation could lead to increased rates for policyholders, we have not seen any data to support this. For well over 125 years, life insurers and applicants did not have genetic testing information, and business managed to flourish. We think it's unfair for insurers to base issuance and pricing decisions on information that's relatively new and completely unnecessary for the sustainability of their business. 14 other states have passed protections to address these insurances. Our bill encompasses 3 types in one. Maryland has already addressed long-term care insurance 15 years ago, and we're hoping to bring life and disability up to the same standard. Thank you for your time, and we request a favorable report for House Bill 155.
Who will be next?
I'll go next.
You don't have to touch it.
Oh, sorry. Thank you, Madam Chairwoman and committee members. My name is Colleen Balas, and I am the President and CEO of the ALS Association. On behalf of all people living with ALS, including the 224 families here in Maryland, we respectfully request your support for House Bill 155. If passed, life insurance, long-term care insurance, and disability insurance companies operating in the state would not be able to charge higher premiums or refuse to insure a patient that has undergone genetic testing. requested genetic testing, or because of the results of that genetic test. ALS, or commonly known as Lou Gehrig's disease, is a fatal, progressive neurodegenerative disease that slowly robs someone of their ability to walk, to talk, to eat, and eventually to breathe. There is no cure, and we don't know what causes ALS. At the ALS Association, our goal is to make it a livable disease by 2030. Genetic testing is a critical component to understanding the disease, treating it, and hopefully preventing the disease. We do know that currently at least 10 to 15% of people with ALS have what we call familial ALS, meaning they have a specific gene mutation and that it's hereditary. This is a specific population and it's unique. And we are seeing clinical trials for gene therapy to treat families with ALS across the country, around the world, and even here in Maryland at Johns Hopkins. We also know that the more people that participate in genetic testing, the more companies are incentivized to invest in gene therapy trials for a variety of diseases. Under the federal law, genetic and not GINA, health insurers are prohibited from using information learned through genetic testing, such as gene mutations linked to ALS. Employers, likewise, protected from being fired or based on genetic tests. We thank you for your time and appreciate you considering Bill 155. Thank you.
Next, please.
Good afternoon, Chairwoman Pena-Melnick, Vice Chairman Woman Kelly, and members of the House Health Government Operations Committee. I appreciate the opportunity to speak to you today about House Bill 155, the Genetic Testing Protection Act. This important piece of legislation could save the lives of future generations, potentially my relatives. My name is John Knowles. My wife, Terry, who's sitting with us in the audience with her sister, Jeanette, was diagnosed with ALS in March of 2021. Her identical twin sister, Mary, died from ALS in 2013, and her sister, Patty, died from it in 2020. When Mary was diagnosed, there was no history of ALS in our family. Diagnosis was done through a process of elimination, as there are no blood tests or any tests for that matter that confirm the diagnosis. There are, however, genetic tests that indicate a person may have a gene that is linked to ALS, but even these tests only provide a possibility. Terry comes from a family of 7 sisters. Terry and I live in Ashton, Maryland. Other Maryland-based families live in Germantown, Mount Airy, Frederick, and Brunswick. All were married and together produced 16 children, and currently a next generation of 3 children. The children, including my own, are all at that time in their lives where they are marrying and adding to the family. Several of them have undergone genetic testing, but most of them have not. It is sobering when the geneticist during the test warns you that if you carry a gene defect linked to ALS, it will likely cause you to either pay higher insurance rate or be denied insurance altogether. So they suggest if you're contemplating getting life insurance, long-term care, or disability insurance, you should get it before you get tested. Back in 2009, when Mary was diagnosed, the process was bleak, and there was only one drug available to help slow the progress of ALS. Today, I'm happy to share there are 3 approved drugs to slow the process, and there are numerous drugs under development and in various stages of testing that show promise on slowing and hopefully curing the disease. We are teetering on the pinnacle of so many companies and researchers finding a cure. Some of these treatments may one day be used to treat non-symptomatic patients who have one of the genetic defects. But without genetic testing, Maryland citizens who could get early proactive treatment won't, because they've put it off due to concerns about being able to get insurance. Today, my wife Terry is slowly getting weaker. The progression of the disease is following the same path we saw in Mary and Patty. She is on 2 of the drugs approved to slow the disease and is enrolled in one of the trial drugs currently being tested. Terry recognized early onset of the disease because she is a physical therapist who also helped care for her 2 sisters as ALS slowly took their strength and their ability for their muscles to work. After her second sister, Patty, was diagnosed, it was evident that it was the familial version, and since Terry shared identical DNA with her twin, we knew that she had the genetic defect even without testing. It was a major factor in both of us retiring early to have as many years together as possible. I mentioned earlier that some of our relatives have undergone genetic testing. They did this in order to be involved in a national study that is following relatives of patients with familial ALS to try and learn why some people develop it and others don't. With that said, they underwent testing knowing that it may have a negative impact on them, but hopefully will assist in finding a cure. For our family and others like us, passing of this legislation will take away one worry, and it will provide an avenue for those who want to take genetic testing to discover if they have a gene defect, to be open to being involved in studies and future treatments to prevent them from developing this debilitating disease. As someone who has been impacted by insurance companies canceling insurance due to my wife's diagnosis, I can share that my life already has enough complications without an insurance company that has profited from my premiums deciding that her diagnosis should allow them to cancel our policy. I'll close by saying, if you, your family, or friends have never been impacted by a diagnosis of ALS, be thankful. Watching your loved ones slowly become weaker, eventually losing strength in every body muscle is heartbreaking. Thank you for taking the time to listen to our story and for your support for this important legislation.
And the committee, on behalf of the committee and myself and our staff, I'd like to thank you for sharing your personal story. I see your wife in the audience. I want to thank you for sharing your story, and I send you prayers for healing. Thank you for being here.
Thank you.
Who's next?
Good afternoon, Madam Chairwoman and members of the committee. I'm Dr. Neil Thacker. I'm the Chief Mission Officer for the ALS Association, and I appreciate the opportunity to speak to you in support of House Bill 155. One of the greatest scientific achievements of our time was mapping the human genome, a project that was led here in Maryland. And now the state and this committee have another opportunity to lead in advancing medicine through House Bill 155. If passed, this bill will provide the protections required to realize the full potential of genetic science. We're living in an era of unprecedented change in ALS care. We've discovered more than 40 genes that either cause or increase a person's risk of developing ALS. At least 10 genetic therapies are being tested in clinical trials, with almost a dozen more being developed preclinically. One such study that's underway now is at Johns Hopkins, and it goes even further. It aims to prevent ALS from developing in people with an ALS gene mutation but who show no symptoms. So just imagine the impact of this technology. We could stop ALS before it starts, saving the tremendous financial, social, and emotional costs that are caused by ALS. A major barrier to this progress is that few people with ALS and their family members know their genetic status. It makes it difficult and time-consuming to recruit for these gene-based studies and slows down our fight against ALS and every other devastating illness with a genetic component. Fear of their genetic information being used against them is one of the reasons why people say they don't get tested. Thus, the threat of genetic discrimination creates a serious dilemma for everyone in Maryland. Either we risk our own physical health because we don't know our genetic status, or we risk our financial health because we do. While this threat remains, it not only can harm the health of Marylanders, but also slow down the massively important science being done in the state. House Bill 155 will remove that threat, helping bring life-changing genetic therapies to everyone who needs them faster. I urge you to support this bill, and I thank you for your time.
Thank you for your time. Who's next?
That's it.
You're done?
That's all.
Okay, sorry. I should put my glasses on. So this is actually the panel for the sponsor. Are there any questions for the sponsor and for his witnesses? I'm going to start with Delegate Rosenberg, followed by Delegate Johnson.
My question is for the doctor, because I assume you'll be best able to answer this. Lou Gehrig was honored, or Lou Gehrig Day was over 80 years ago. With all the attention that his disease has gotten, why is it, I'm just curious, why have we made, maybe we've made more progress than we think, but why, given what we've done with cancer and heart by contrast, why has this taken so long?
Yeah, that's a great question. And ALS is just a very difficult disease. As Colleen was mentioning earlier, we don't really understand what causes it. There are a number of pathways we've identified and a number of genes that we've identified, and they're all under study. And so as this pace of research has increased, Our treatment options are increasing as well. There was a new drug that was approved just last year, and there's a new genetic therapy that may be approved this year as well. So things are getting better, but not quite fast enough, and that's why we need to really keep the pressure up and keep fighting.
Delegate Johnson.
Thank you, Madam Chair, and thank you, panel and delegate, for bringing us this bill. We like to look at all sides of every issue to make sure we make the best decisions for Marylanders. And you've brought up ALS, so I have to ask the question that pertains to the life insurance part of this bill. Would it not be possible for the life insurance part of this bill for someone to find out they have ALS and then go get the largest life insurance policy possible without the insurance company having all disclosure of an illness? And do you think that that would heavily impact the life insurance industry for all Marylanders?
Who's the best person to answer?
I can speak to that. I mean, this bill doesn't do anything about what is already accessible from a medical record for an application. If someone were to go to a life insurer with the diagnosis, it would be clear to the you know, whoever is filling out for their life insurance. This is specifically for the genetic test marker. The genetic testing will still be accessible to the life insurer, but this bill is hoping that they won't be able to discriminate someone based on that test.
It's also worth noting that you're asking a theoretical question.
1 second, why don't you, we only allow one person to answer.
I'm sorry.
Maybe the delegate, I would allow a follow-up and he can ask you a question.
Would you like to embellish on that?
Thank you, I appreciate that. You're asking a really great question, and it's a theoretical question, but there is experience of this happening in other places, and we don't have information about increased premiums in states that have passed similar laws. And so we've reached out to insurance departments, I think in New Jersey and Arizona and Maine. We're just not seeing the data that this is happening. It's not happening.
My pleasure. Delegate Hill.
Thank you, Madam Chair, and thank you all, and to the gentleman who testified about his family situation. One of my closest friends just died of ALS less than 3 months ago, so I definitely understand. Delegate Kipke, it's such a progressive idea of yours. I'm so pleased. So what I'm trying to understand is if, in essence, what you're saying is we're going to draw the line, information that insurance companies can use now to make their actuarial analysis. That's all fair, and they can ask people about family history and who's had stuff, but you can't actually test for stuff. But they are allowed to do things like test to see if your A1C is elevated. They're allowed to have you go get a screening test for your eyes, and there are a bunch of things. Why is this where you want to draw the line? And why is that not giving them as business people, you know, a really put them in an unfair position, particularly since we had to do so much adjustments in our long-term care because they underestimated what the real cost of that insurance was going to be?
Well, my friend from Howard County, the very progressive governor of Florida, Ron DeSantis, enacted this law as it relates to life insurance, and I think also long-term care. We already have it on the books for long-term care in Maryland. And I asked the same question that Delegate Johnson asked when I was reviewing this bill. And the practical analysis of it is the fears. I mean, there may be an individual who might try to game it. But remember, your monthly premiums are going to be through the roof if you try, you know, there's an affordability issue for that individual. Can they afford to do that? But practically speaking, many people are going to, as it advances, genetic testing advances, you're going to be able to screen for more and more things. So this is going to be an ever expanding practice that helps inform people. And it does, like, as you know, it does not necessarily mean that you're going to end up with the breast cancer or whatever, or AL, whatever it may be. But information is power, and it helps you inform your healthcare choices. And the fear of the negative outcomes or the disturbance in the insurance market isn't happening in our long-term care market in Maryland. That's a whole other problem, people living longer and all that. So the concerns that I think are normal reactions to something like this just hasn't bared out the fruit.
See, for those new ones on the committee, you didn't know you were going to get a PhD in insurance, right? Delegate Bagnall, I thought I saw your light.
Delegate Kipke answered my question.
Wonderful, thank you. I don't see any other questions, Delegate Kipke. Thank you very much.
Thank you.
And thank you to your panel. We do have Lisa Peabody and Sarah Berth. Will you be so kind and come up, please? In addition, I like to see Matt Kramer and Melanie Lennell. All of you, please come up. And will you get started as soon as you sit? Thank you.
Hi, thank you. I'm back from this morning. I'm Lisa Peabody, and I'm a constituent of Maryland, and I'm the advocacy manager at FORCE. And I'll remind you that FORCE is a national nonprofit that serves those who have a high risk of cancer due to a family history of cancer or a noted genetic mutation. Knowing that you have an inherited genetic mutation puts you in the driver's seat, as we have been talking about, to proactively affect and possibly decrease your cancer risk for some cancers. This high-risk group can follow medical guidelines to increase the frequency of screenings, start screenings at younger ages, and possibly make the decision to go risk-reducing surgery like a mastectomy or removal of ovaries and fallopian tubes. Increased screenings and preventive measures actually make members of this community the best candidates for insurance coverage. Tragically, some people refuse genetic testing, getting out of the driver's seat with their cancer risk, fearing that identifying a genetic mutation will impact their ability to get insurance. This doesn't mean that they don't have a genetic mutation. All that it means is that they're choosing not to test and not to take their health and be in the driver's seat. It doesn't even change their cancer risk. It just means that they are choosing to be uninformed. Take Lynch syndrome. So Lynch syndrome is a group of inherited mutations that causes up to a 60% risk of colon cancer. In fact, it affects 1 in 300 people, and somebody in this room may even have Lynch syndrome and don't even know they have it because it's so common. But Lynch syndrome carriers can mitigate their risk because their risk of colon cancer can be decreased by increased screening and the removal of suspicious polyps. It's vital to know whether or not you have Lynch syndrome so you can start your screenings earlier and do them more often. So we can't allow the fear of the inability to get insurance to prevent people from getting genetic testing. We hope you will endorse HB 155.
Thank you. Who's next, please?
Madam Chairwoman and committee members, I'd like to thank you for the opportunity to speak in support of House Bill 155. My name is Dr. Sarah Berth, and I'm a physician and assistant professor in neuromuscular medicine at Johns Hopkins Hospital. I see ALS patients in our ALS multidisciplinary clinic, which is one of the largest in the nation. I'm a member of our ALS clinical trials unit, and I also research genetic causes of ALS. ALS is a relentless and fatal neurodegenerative disease, robbing patients of their ability to move, speak, swallow, and breathe. And mortality for this disease is still within 2 to 5 years of symptom onset, and there is no cure. Now, 10 to 15% of ALS is inherited, meaning that these patients have a genetic mutation causing ALS. Over 40 mutations have been found that cause ALS, and I expect that more will continue to be discovered. Now, the treatment landscape is rapidly changing for our patients with genetic causes of ALS. There's now a pipeline of drugs being developed to target the specific genes that cause ALS, which offers a tremendous impact to our patients. In fact, one of these such drugs will be undergoing FDA review shortly in the next few months. Now, these genetic treatments hold great promise that they can provide the possibility of extending life or even halting the progression of the disease. And because of this, expedient genetic testing is absolutely necessary so that these patients can be directed to and receive their appropriate treatment in a timely manner before they develop profound disability. Now, this HB 155 bill is important because it helps to protect these patients and prevent them from having to delay or even forego genetic testing due to concerns about the ability to receive life insurance, long-term care, or disability insurance. And because of this, as a physician, I am strongly in support of House Bill 155 and believe that this bill would provide important protections for people with ALS, among many other people who suffer from genetic disease.
Thank you for being here today. Next, please.
Chair Pena-Melnick, members of the Health and Government Operations Committee. For the record, my name is Matt Kramer, and I'm here in support of House Bill 155. Several of you I know through my work here at the General Assembly as Delegate Welsh Chief of Staff. However, today I'm before you as a son who lost his mother to ALS November 1st of 2021. My mama, Ann Kramer, was a devout Christian, a fierce advocate for children, and lived a selfless life that inspired so many around the world. My mom is the strongest person I have ever known. Watching her fight this disease, all while continuing to be the kind, generous, and compassionate mom she was, is a strength most of us will never see in our lifetime. During my mom's final months, she requested genetic testing be done because she did not want to leave this life knowing that there was a possibility her ALS could be familial and that it could be passed down to her children. For weeks, we all waited. My mom's case ended up being sporadic, but had that ended differently, her children would have had to take this test to know what could be ahead for them. My family and I are in a place of privilege that we would be able to tackle these things head on, but so many facing ALS are not. My mom was never able to get the long-term care insurance she needed, so my father and I were by her side all day, every day, even the moment she passed away in my arms, because we had that ability. It's shameful to think that we would put profit over the dignity of someone's life, my mother's life, any of us here. And by letting this bill fail, that is what we will be doing. Discriminating against someone because of a disease that we do not know the cause of is disgraceful. There are no preventative measures. There is no cure. There is just giving dignity to the end of life that we deserve. It is with this that I ask for your support for House Bill 155.
Thank you for sharing your story with us, and your mom is smiling. She's very proud of you right now. Who's next?
Good afternoon, Madam Chairwoman and members of the committee. Thank you for giving me the opportunity to speak to you today about House Bill 155. I am Melanie Lendenal and Senior Vice President of Advocacy at the ALS Association, but today I find myself here in a very unique position. While I am certainly here as a patient advocate, I am also here as a resident of Montgomery County, Maryland, a person with a long family history of breast cancer, and what I consider to be my most important title, a mom. Numerous studies have demonstrated that fear of discrimination by insurers is real, and one of the primary reasons people choose not to get a genetic test. I am one of those people. Every single woman on my mother's side of the family, going back to my great-great-grandmother, has been diagnosed with breast cancer, including most recently my mother. And while my doctors have encouraged and countless researchers have literally begged me and other members of my family to undergo genetic testing for their studies, I have flatly refused. I am a mom. And above all else, I need to know that if anything ever happens to me, my daughters will be okay. I need to know that whatever insurance I choose to purchase now or any time in the future will not be out of reach for me or my family financially. Passing this legislation will make a difference to so many in this state by removing just one of the many barriers that force people like me to have to choose between their physical health and their financial health. Therefore, I respectfully ask for a favorable report on House Bill 155 today. Thank you for your time.
And thank you for sharing your story. Are there any questions for this panel? Seeing none, thank you for being with us. Really appreciate you and your time. And all of you that are waiting, they still have 2 more bill hearings. Thank you for being patient. We will get there shortly. Next, we have Matthew Chantilano, and we have Michelle Foster, and we have Dr. Dave Rangancheri. Good afternoon. As soon as you sit, will you be so kind and get started? Thank you.
Good afternoon, Madam Chair, members of the HGO Committee. My name is Matt Celentano. I'm here today on behalf of the League of Life and Health Insurers of Maryland and ACLI in opposition to House Bill 155. That being said, ALS is awful. We all know that. We all agree that we want a cure, and that's what we all should be striving towards. But I want to start my testimony by relaying that life insurance is fundamentally different than health insurance. Life insurers get one bite at the apple. We build a rate that is based on you with the information that we have available. The policy lasts for decades or more, and nobody, not a single carrier, ever requires a genetic test. We would never require a test. There's no raising of rates like health insurance on a yearly basis. We don't get to review the policies like that, and it can never, ever be canceled. Regardless of what happens to your medical status, your policy can never be canceled. It is with you for your life. It is a long-term product, and it is voluntary. This bill has a chance to upset the entire marketplace, and while we totally sympathize with the plight of the advocates, there are very concerning unintended consequences here. Life insurers want to make sure that the majority of Marylanders that buy life insurance products as their sole form of retirement savings can continue to do so. I'm just the trade association person, the representative of Annapolis, but joining me today are policy experts to pass along the real impact of what this bill could do. To my right is Michelle Foster, who works on risk classification at the American Council of Life Insurers, and Dr. Dave, who is a medical director with the carriers, will be able to provide you any insight and answer any questions you might have. Also, before I finish my testimony, I just want to point you to a letter from the Maryland Insurance Administration, a letter of information that should be in your bill file, that clearly lays out that this bill is extremely problematic. And as much as we have heard that there are other states that have done this across the country, there really isn't. There's no state that's done this, not even Florida. Florida has a bill that's similar to this, but there is legislation underway to repeal that bill because of the impact of the life insurance market. The other states have nothing that doesn't let us look at the medical record. So I respectfully ask for an unfavorable report.
Who's next?
Good afternoon, Madam Chair, members of the committee. My name is Michelle Carroll Foster. I am the Regional Vice President of State Relations at the American Council of Life Insurers. ACLI is the leading trade association representing the life insurance industry. Each day, life insurers pay out $35.4 million in life insurance and annuities to Maryland families and businesses. ACLI strongly opposes HB 155. Since 2019, 15 states, including Maryland, have considered such legislation, with only one, Florida, enacting in 2020. The rest have either failed or were amended to protect life insurers' access to all of the applicants' medical information, including genetic testing results in the medical record. As it relates to Florida, as Matt mentioned, introduced legislation this year to reverse its course and permit the use of genetic test results in underwriting if they're part of the applicant's medical record, and that is what we're asking for. You may have heard the proponents mention the Genetic Information Non-Discrimination Act, which is GINA, in its application to only health insurance and employment. However, to be very clear, life and disability insurance was purposely excluded due to the unique structure of the products and the market. Exclusion of life, DI, and LTC from GINA was not an oversight. It is important to understand that life insurance is voluntary. We do not require or request applicants to undergo genetic testing. Unlike health insurance, there's only one opportunity to evaluate a person's risk before issuing a policy that will remain in place for a lifetime. Once a policy is in place, it cannot be canceled and premiums cannot be raised because of changes in a person's health or subsequent test results. Insurers have to be able to properly underwrite, and HB 155 would prohibit it. Properly underwriting maintains solvency and financial strength, and it protects affordability for all policy owners. In closing, it's important to know that inherited conditions do not always mean applicants will pay more or be declined. With that, I respectfully ask that this committee report this bill unfavorably. Thank you.
Thank you for your testimony today. We have next.
Thanks, Madam Chair. Thanks for the opportunity today, hopefully to provide some unique perspective. As I spent over 10 years as an insurance medical director and in underwriting, working to provide...
Give us your name, please.
Oh, sorry, Dr. Dave Ringacheri, testifying today on behalf of ACLI. I spent more than 10 years in underwriting, working to provide more insurance to more people with complex medical conditions. But I've also spent 10 years as a clinical neurologist, taking care of and advocating not only for patients with ALS, but a wide variety of neurologic conditions. We've heard today some very poignant concerns around harm, but I too would like to discuss harms and really the unintended harms that this bill would introduce. The first of these is harms to people with other non-genetic medical conditions. To be clear, this is not an ALS bill. This is not a research bill. This is a total ban on the use of genetic testing in life insurance, long-term care, and disability. And it violates a really important principle in insurance medicine. We don't play medical favorites. We see teachers with multiple sclerosis. We see mothers with strokes. We see police officers with spinal cord injuries, none of whom asked for their disease. And when we start playing favorites with all the people with any genetic condition, it is the most vulnerable of those without a genetic condition who first paid that price. Second, and this is counterintuitive, the bill as written would harm the very people it would be trying to protect. Only a small portion of ALS is genetically determined, but under this bill, we couldn't use the test results even if the test results were negative. So we would have situations with individuals with a family history of ALS, negative testing, but we could not offer a favorable policy. Finally, and make no mistake, this bill seriously harms Maryland consumers. Maryland consumers would be asked to bear protection costs for every individual with every genetic condition for every amount of insurance, $10, $20, $30 million. And Maryland consumers would need to support every residents of every state who would quite logically come to Maryland for such policies. It's for that reason we can't be in favor of this bill.
Thank you for your testimony today and your time. Are there any questions from the committee? Delegate Bandari.
Yeah, thank you, Madam Chair. I read your testimony a couple of times, ACLI testimony. While reading the testimony, I will be very honest, like genes should determine our fate. The only way to get affordable insurance is to engineer ourselves to a perfect specimen genetically, which is not possible. And hopefully nobody start the genetic equality now movement with Kipke. The real question is, what steps could be taken to address the potential negative consequences of incorporating genetic information into underwritings, such as discouraging people from seeking preventive care and resulting in discrimination and unequal access to insurance coverage? Are there alternative approaches to ensuring a level playing field? In your testimony, you have talked a lot about the level playing field to the doctor.
Yeah. Yep. So I'll begin by saying you're exactly right. We are all not perfect people, but we're not all perfect people for both genetic reasons and for non-genetic reasons. And genetic testing, while it's new, is just one of only a myriad of screening tests that are out there. So we've heard today, actually, about mammograms. We've heard today about colonoscopies as important screening. And we've never heard arguments or seen data that people are not getting their mammograms or their colonoscopies for fear of life insurance discrimination here. Nor have we ever seen arguments that someone should be able to go out and get a mammogram and get a colonoscopy, and only once they receive the adverse result, then apply for the life insurance policy, not able then to look at that initial round of testing. So I would go back to this idea that we really start to introduce harms when we try to create these artificial barriers between genetic and non-genetic testing. There's absolutely a fear element to be overcome, but I think that's quite possible because we've done so now for decades with a variety of new screening tests as they have emerged.
Delegate Collison, followed by Delegate Taveras, followed by Delegate Johnson.
Thank you, Madam Chair. I think this question, I'm not sure if it's for Dr. Dave or Michelle. So I want to be clear. There are many factors that go into calculation of rates for individuals, right? So life insurance, long-term care insurance is based on individual factors. I haven't finished the question yet, but I'm just affirming. And it's based on underwriting, which regular health insurance is no longer based on underwriting. And it's based on underwriting because it is a permanent product for the life of the person. So what are some of the factors that are considered in underwriting? And that's number one. And would the genetic testing results necessarily, or would they prevent the individual from getting life insurance, or would they be able to get it? It's just going to be at a rate which is, I understand that it might be higher. My life insurance policy is higher than someone else's in this room just because of my size. So they would be able to, my question is, would they be able to get insurance even if they had a genetic test in their file? Stop.
Thank you for that question. And if I could step back just briefly a moment and describe the process of underwriting. So underwriting is making an accurate assessment about the mortality or the morbidity of an individual, and is making that assessment which needs to hold true 20, 30, 40, 50 years into the future. So it's a very daunting process. But you're absolutely correct. It is at its core a holistic process. We take in every factor that has relevance to morbidity and mortality there. And that could include factors such as your age, that could include factors, favorable factors, such as the preventative measures that you may be undertaking there. It could include social habits, whether you drink or too much or smoke, and it can include a wide variety of medical factors. And I would say because it's such an encompassing process, for the overwhelming cases, the genetic information is just a piece of that process there and would be rarely the deciding factor. But when it is, it's because to issue a policy would be fiscally unsound if you would ignore that information.
Delegate Taveras.
Thank you. Well, I would like to say I'm a special specimen, but if I'm not, then Lizzo at least says I'm special.
Delegate Taveras.
For the
what's your
insurance
question?
carriers, please, what is the problem with the exemption from the prior authorization on genetics?
I apologize. I don't understand the question.
Oh, I'm sorry. I might have mistaken this. So, wait a minute. 27909 in the section of MIA clearly indicates that while there are prohibitions on insurers on nonprofit health services plans, it expressly exempts life insurance policies and disability insurance. And this is what we're trying to correct in this particular bill.
Yes. Right now, according to the MIA's letter, that section expressly exempts life insurance, long-term care insurance, and disability insurance. What this bill would do would include those three products.
Okay.
Thank you.
Thank you.
Okay, Delegate Johnson.
Thank you, Madam Chair, and thank you, panel. Can an individual with a terminal illness be turned down for life insurance?
That is correct. If an individual with could be turned down for individual life coverage. There are other avenues for that individual to receive coverage. On a very practical level, the majority of those individuals would receive coverage through a group employer policy.
Thank you. Thank you, Madam Chair.
My pleasure. Delegate White.
Thank you, Madam Chair. I have a question related to, and I guess maybe this is for Dr. Dave, you could answer this, but could you explain the difference between genetic testing and a diagnosis and how those factors are used as part of the decision? Because genetic testing does not translate to diagnosis. So can you give us a sense of how those are weighted in your decision?
Yes, thank you very much for that question. I would answer that in two ways. I would answer that by going back to what we mentioned before, which is we are making estimates around 30, 40, 50 years into the future. So for the overwhelming amount of information that we are using for that process, it really is based on risk factors. So things, for example, like high cholesterol there. That's not a diagnosis, but it's very important for assessing the morbidity or mortality of that individual. And many genetic testing fall into that risk factor type of category. But the second important distinction that you made is also critical to answering a question which was posed earlier, and that is that difference between this bill around testing and diagnosis. So this bill would remove the ability to make a decision based upon testing alone. So it's very, very, very feasible for an individual to get the testing, get the positive result, before they receive the diagnosis in the medical record. They would apply for a policy, again, 10, 20, 30 million dollars. And that's where it becomes, and quite frankly, wouldn't we all, right? There. And that's where it becomes quite unsustainable if we get 1, 2, 3, 4, 5 of those type of policies.
Yeah. Delegate Hill.
Thank you, Madam Chair. So let me just follow up with that. You all use a range of actuarial information to determine someone's risk category. Some of it may not be used today, but you look at race, sometimes you look at fitness standards, you look at family history, health patterns and behavior, and you make decisions. But those things, and you make harsh decisions sometimes on things that are really not as predictive as they might otherwise be. So how does not having genetic information change that? So, right? So you're going to make the same decisions based on sort of arbitrary actuarial analysis of this other data.
So let me answer that in two ways. So first, let me correct one thing I have to. We do not make decisions based upon race or any protected class there. Second, we're underwriting. We're not actuaries, okay? And in underwriting, we don't begin with the table or the calculation. We begin with the individual. And we begin with what that individual tells us. And we begin with then very often the medical records on that individual there. We have every incentive in the world to try to cover as many people as possible. Every time we underwrite a policy that we decline, we've lost money there. So we are doing everything that we can to cover as many people as possible. When you begin, however, to remove information from that individual's record that's important for making an accurate assessment there, you're making a promise to that individual that you can't cash in 50 years. And that's fine if it were one individual here, but when you start to get groups of individuals who by law you've specified you can't use that information for an entire block of individuals, that's when you get unsustainable policies. So it's not a question of actuarial tables. It really is a question of the inability to accurately assess an individual at the individual level.
Afterwards, because I don't quite follow that. Thank you.
Any other questions for this panel? Delegate Lewis.
Thank you, Madam Chair. Small question, and I think I would direct this, the person best equipped might be the doctor. Would a person with a genetic test, a positive genetic test result for an ALS marker be able to receive a life insurance policy?
So, and I'm not trying to be coy about this, but it depends, right? Because we just mentioned before that it is a holistic process, right? And so it depends upon the marker there. It depends upon that individual's the remainder of their medical history there. It depends upon their family history there. And then it depends upon the type of product that they are applying for. So it's not quite to say that there would be some instances that they would and there would be some instances that they would not. But again, I go back to the fact that it's putting all of the pieces together. And when you need all of those pieces to make that accurate assessment.
Members of your life insurance pool that have a genetic test, a positive genetic test for ALS. Does your company, or are you aware of any companies that cover, have a person with that qualification?
Yes, there.
My pleasure. Seeing no other questions, thank you for being with us today. We really appreciate it. Next, we have a virtual testimony. And for the committees, this is actually information. This is the last witness for this bill. And it's Lisa Schagler. Actually, it says virtual in both. Is she waiting? Okay. Good afternoon. How are you? Nice to see you again. You have to unmute yourself.
Thank you. I'm sure you're all tired of hearing about this at this point, but...
Tell us your name. Thank you.
I am Lisa Schlager. Good afternoon, Madam Chair and members of the committee. I'm Lisa Schlager, and as I shared earlier, I serve in a professional capacity with Force, the national nonprofit you spoke earlier, but I'm here today to share my family's story. In 1999, I find out that I carry an inherited BRCA1 genetic mutation that significantly increases my risk of breast and ovarian cancer. I learned about this mutation after taking part in a research study for families that had a family history. And I feel blessed. I actually feel very fortunate to have this information because it has given me the power to be proactive with my health. I've been able to catch cancer early, or in my case, prevent cancer altogether because I had access to that information. But go back to 1999. I was 32, just married, looking to start a family. And luckily, 20 years ago, these mutations were not on the radar of most life insurers or other types of insurers. Still, I was told to ask my doctors not to put that information in my medical record because it could be used against me for health insurance purposes at the time. The ACA didn't exist, so I could have been denied health insurance just because I had a genetic predisposition to a disease. Thankfully, we're not there anymore. But this is, I was able to get my life insurance with no problem, but that is not the case today. People in our community are being denied insurance simply because they have a genetic mutation, not because they have manifest disease. Our 22-year-old daughter is in a tough spot. She's been advised to get tested for the mutation by 25 when she would need screening or to undergo preventive surgery. And everyone says, oh, just get life insurance before you test. But most young adults are not in the position where they can or should invest in life insurance at that age. Getting tested and risk are very different things. Many people are delaying testing or not testing at all. My own brother refuses to test because he's the breadwinner for his family. And he's rightfully concerned that if he needs additional insurance, he won't be able to secure it. That doesn't mean he doesn't have the mutation. It just means he's choosing to be uninformed. So in fact, he's a worse investment for the companies than I am because I have been proactive with my health. This is why insurers should be prohibited from using this genetic information in their coverage decisions. Please think about this and endorse HB 155. Thank you.
Thank you. Are there any questions for this witness? Seeing none, thank you very much for being with us today. And this actually concludes the bill hearing on House Bill 155. Next, we have House Bill 107, Delegate Lewis. Will you be so kind and bring your panel if you have one? Maryland Health Benefit Exchange, Small Employers, Special Enrollment Period and Marketing. And as soon as you sit, if you will be so kind and start with your testimony, I really would appreciate it.
Thank you, Madam Chair.
My pleasure. Please don't touch the buttons. They're a little fickle, okay?
Thank you, Madam Chair. Thank you, Chair Peña-Melnick, Vice Chair Kelly, esteemed colleagues on the Health and Government Operations Committee, which is the best committee. I'm Delegate Robin Lewis, testifying on behalf of House Bill 107, which is designed to close the health insurance coverage gap in Maryland. Now, those of you who've been in the legislature for a while know that we are committed to covering every Marylander. We believe that every person who has health insurance can get access to health care, and that is our goal. Over the last decade, this legislature has successfully passed bills to expand health coverage so that more and more Marylanders are covered. We're approaching that universal coverage goal. We've shrunk the uninsured coverage rate from 10.2% in 2013 to just about 6% in 2021. And we did this by breaking down barriers to enrollment. Whether it's premium costs or the complexity of the enrollment process, we've done so much to break down those barriers and enfold the people of our state in coverage. Well, this bill, House Bill 107, will break down one of the last most intractable barriers to health insurance enrollment, and that's awareness. That's knowledge of the opportunity of the products that can be used to cover people. Awareness raising is still very much needed, and there are tax credits that some folks are eligible for that they don't know about, and it prevents them from enrolling. So this bill will invest in awareness. It funds a marketing and outreach campaign that's targeted to small businesses. Now, I want to draw your attention to the fact that the bill, although the bill title, the current title, includes the word special enrollment, I want you to just ignore those words because I've received feedback from advocates, and we feel that the amendments suggesting that special enrollment concept should be eliminated. I've agreed to, I consider it friendly. So the bill really doesn't touch special enrollments at all. It focuses instead on marketing and outreach. I'll mention, in case you're not aware, that in the state of Maryland, small businesses constitute an enormous, productive, and far-reaching component of our state's economy. Small businesses in Maryland employ about 1 million people. That's about 1/6 of our entire state's population. Small business owners in Maryland are mostly women. About 52% of small business owners are women. 1/3 of small business owners are Black, brown, and minority business owners. They are themselves more likely to employ other people of color. So a lot of vulnerable workers are included under the small business umbrella by raising awareness of small business owners, and that includes nonprofit businesses as well, to the availability of subsidies for their workers to buy insurance, we believe will go a long way to closing that coverage gap. I'll mention also that if this bill seems familiar to some of you who were here last year, you are not having you're not hallucinating. It is, in fact, deja vu. This bill should be familiar because it's the product of a work group bill that I passed last year. The work group recommended that this bill be developed and introduced, that we invest in awareness raising for small businesses and close that coverage gap. Finally, I'll just end by saying we've done so much so far. Raising awareness among small businesses and nonprofits is the right thing to do, and I hope you'll join me in supporting this legislation. Thank you, and with that, I would like to include my panel. There are several members that should be with me: Johanna Fabian Marks, Stephanie Clapper, Lane Levine, Neil Bergsman, Rikara Jones, Jake Whitaker, and Lee Hudson, and maybe one person virtually, Jamal Lee. With that, thank you, Madam Chair.
Thank you. May I please call on Stephanie Clapper, and I'm calling it the way I have it in the sign-up sheet, okay?
Thank you. I'm Stephanie Clapper, Deputy Director with the Maryland Healthcare for All Coalition. Chairman Yemelnik and members of the committee, thank you for this opportunity to testify in favor of House Bill 107. I am here representing over 300 faith, business, labor, community, and healthcare organizations across the state that all stand united supporting access to quality, affordable healthcare for all Marylanders. Thanks to your committee's leadership, over 400,000 Marylanders have enrolled in coverage since the passage of the Affordable Care Act, and we've made great strides towards achieving health equity through legislation like the Health Equity Resource Act. Yet we still have more work to do. Still 6% of Marylanders remain uninsured, and inequities by race and ethnicity persist. Many of the uninsured work for small employers. Only 37% of small employers offer health coverage to their employees. And in Maryland, we actually have the most per capita small businesses owned by Black and brown people in the entire nation, something we should be proud of, but can also be a factor in these health inequities persisting. I was proud to serve on the work group that was created under legislation that your committee passed last year. There were small businesses, nonprofits, insurance carriers, and producers that were all represented, and after much discussion and review of the data, including changing federal policy, we did recommend an outreach program about how small employers and their employees can access health coverage, both through traditional small employer coverage and through the individual market with the help of federal subsidies. This legislation will help reduce the uninsured rate in Maryland while at the same time supporting small employers, because when their employees are healthy and productive, that will benefit them. It will also help improve health equity in our state. Thank you, and I urge you to support House Bill 107.
Thank you for being with us today. We really appreciate it. And next I have, actually I don't see her there, but I'm going to call on Rikara Jones. Yeah, don't touch it.
All right.
Yeah, there it goes.
My name is Rikara Jones. I'm the political director with 1199 SEIU, United Healthcare Workers East. We are the largest healthcare workers union in the country. We support this bill to help small employers and their employees get connected with health coverage through the outreach program, because we simply just want to get more people covered. And to do this, we have to make sure that the employees know about the program. This is really important to us and our members because our healthcare workers in hospitals and in clinics, they see firsthand how critical insurance coverage is for their patients. When residents have access to insurance, they don't delay preventative treatments and services for major health conditions and chronic diseases, and they're less likely to end up using the ER as their doctor's office and overwhelmed by costly medical debt. We know that a lot of small businesses are having a tough time hiring right now with staffing, but this will benefit them. It's going to help with employee retention and recruitment while also improving health equity across our state. So we urge a favorable report for HB 107, and thank you for the work that you did on this last session.
Thank you very much. Who's next? Tell us your name.
Hi, Chair Pena-Melnick and members of the House Health and Government Operations Committee. Thank you for this opportunity to testify in support of House Bill 107. My name is Lane Levine, and I own A Friendly Bread, a small packaged food business in Maryland. It is an unspoken assumption among newish small food production businesses that health insurance is not one of the benefits any employee can expect. About 2 years in, I was a bit more comfortable with my cash position and decided to look into providing health insurance for my employees. My online payroll processor had a feature that made it easy, and I was okay with the cost. I have employees who began seeing a therapist for the first time in years, and employees who, when sick, were actually able to figure out what was going wrong rather than call out all the time with no hope of solving the underlying issues. I found that some employees saw my company as one of their only good options out there. So When an employee underperforms or turns out to be the wrong fit, my judgment about whether to let the employee go, or the judgment of the employee about whether to leave, is clouded by concern about whether the employee will be taken care of at their next workplace. I want an industry where labor is matched based on business factors, not those of life and death. In order to shift this industry norm, I welcomed the opportunity to join the work group created last year by this committee. First, I learned that I could have gotten a tax credit to offer health insurance. But more deeply, I joined other members of the work group in concluding that better education for employers and employees about existing available options that employers and workers just aren't accessing would be the wisest course of action to lead to more workers being insured. HB 107 would bring the work group's recommendation to fruition by creating a 5-year outreach program that would include education and training regarding existing coverage options. I want to hire employees who feel good about working for me, not just the ones who have nowhere else to turn for health insurance. HB 107 would help both employees and employers find the best health coverage for their needs while helping employers hire employees that best fit with their missions. I urge a favorable report for HB 107. Thank you for your time.
Thank you for your time. Who will be next? Go ahead, Jake. It's on.
Great. Thank you, Madam Chair, members of the committee. My name is Jake Whitaker. I'm Director of Government Affairs at the Maryland Hospital Association, here to testify in support of House Bill 107. We believe that widely accessible health coverage is critical to hospitals providing Marylanders with the best care possible. The outreach program specified in this bill has the potential to significantly increase the number of individuals who otherwise would not have the information necessary to enroll in critical health coverage. As strong proponents of expanding access to health coverage, including health plans offered in the individual market, the Maryland Medical Assistance Program, and small group plans, Maryland hospitals are in strong support of House Bill 107. So for the aforementioned reasons, we respectfully request a favorable report for House Bill 107. Thank you.
You have been around for a while. You did it very well.
Thank you.
Who's next?
My name is Neil Bergsman. I am the Senior Policy Analyst for Maryland Nonprofits. Maryland Nonprofits is the statewide network of all nonprofits with more than 1,700 member organizations across the state. Nonprofit organizations employ almost 13% of the state's private sector workforce. That's more than any other sector except retail. Thousands of Maryland small employers are nonprofit organizations. I represented Maryland nonprofits on the work group. House Bill 107 provides some practical strategies for small employers, nonprofit and for-profit alike, to promote quality, affordable health coverage for their employees. In addition to helping nonprofit organizations and their employees, HB 107 will help the clients and customers of health-related nonprofits. Small business employees are one of the groups with remaining significant numbers of uninsured Marylanders. In many cases, coverage is available to these employees at very low cost due to federal and state incentives. Reducing the coverage gap will help the clients of our nonprofits, whose mission is to promote health, behavioral health, and overall quality of life. For these reasons, Maryland Nonprofits respectfully requests a favorable report. Thank you.
Thank you very much. Go ahead.
Thank you, Madam Chair and members of the committee, for the opportunity to testify in support of HB 107 with amendment today. I'm Johanna Fabian Marks, Policy Director at the Maryland Health Benefit Exchange. As you know, the exchange's mandate is to reduce the uninsured rate and support individuals and small businesses seeking health insurance. And as you've heard, we've come a long way, with the uninsured rate down by half in the last 10 years and exchange enrollment at an all-time high this year. But we still have about 350,000 Marylanders uninsured, about 6% of our population. Data from the census indicate that approximately a third of those work for small businesses. So as you've heard, and as we have a number of individuals on the panel today, we convened a work group at the direction of the legislature to examine how the exchange could better support small businesses. And I think, as you can tell, the work group was very engaged and had great participation from our stakeholders. Their unanimous recommendation was that the legislature provide the exchange with funding sufficient to significantly expand marketing and outreach targeted at small employers and their employees to educate them about their coverage options. These additional funds would enable MHPE to implement a targeted marketing campaign paired with a robust on-the-ground outreach effort, leveraging our partnerships with authorized producers. By investing in this type of outreach, we could both increase the number of individuals enrolled in health insurance in the state and support Maryland's small businesses in attracting and retaining employees by connecting them to the coverage they need to remain healthy and competitive. Thank you again, and I encourage a favorable report by the committee.
Lead Hudson.
Madam Chair, members of the committee, my name is Lee Hudson. I'm with the Bishop's Office, the Delaware Maryland Synod. We are the Evangelical Lutheran Church in America. You've already heard we're in favor of health care for all people in the state. This bill, as we understand it, is basically just a communication device. You've already done the good and heavy lifting to develop the programs that can help more Marylanders access appropriate health care. So I'm just encouraging you to go ahead, State of Maryland, get up on that mountaintop and shout the good news and let people know what's available and how they may access it. Thank you.
Thank you. We have one more panel, sponsor panel witness, and that's a virtual witness, and it's Mr. Jamal Lee. Good afternoon. How are you?
Good afternoon, Madam Chair. Thank you for allowing me to say a word or two. I really appreciate it.
Great.
So my name is Jamal Lee, and I own a small business in Laurel, Maryland. Offering health coverage to our employees has been one of our top priorities. Thank you to the Finance Committee for your leadership last year in passing legislation to create a work group on how to best help small businesses and their employees access health coverage. I was proud to serve on that work group as we met to carry out our charge. Changes in federal law resulted in our recommendation that Maryland invest in an outreach program to small businesses and their employees. HB 107 builds on the work group's recommendation to create a 5-year outreach program that would continue education and training regarding the existing coverages and the coverage options. Our people perish from the lack of knowledge, and too many small businesses in Maryland are unaware of the choices available to them under the Maryland Health Connection for Small Business program. And too many employees are unaware of the financial help available to them in the individual market. This outreach program would help bridge that gap in knowledge and ensure that our workers are healthy and focused on producing great products here in Maryland, of course, in the United States. As a small business owner, building Maryland and contributing to the growth of our country, I am hopeful that you will provide a favorable report to House Bill 107. Thanks for your consideration, and God bless.
Amen. Thank you for being here. I give my love to Nyla and the kids.
I certainly will. Thank you. And you the same for your family.
Thanks. So we're going to open it. He's my constituent. I know him for many years. I am going to now open it up for questions. I have Delegate Kerr.
Thank you, Madam Chair. Delegate Lewis, during the discussions, was there any talk about how this might affect family farms?
Family farm.
Difficult time getting into the small group market. I didn't know if this came up in any of the recommendations.
That's a great question, and I wonder, Madam Chair, with your indulgence, if there's anyone here representing the advocacy groups who could speak to whether or not farms were included. I can't answer that question, but if anyone else can.
Anyone from the panel, will you be so kind? Go ahead.
Hi, I can address that. We didn't have any.
Just for the record, tell us your name.
Yes, Johanna Fabian Marks, director at the exchange. We did not have any farmers in the work group. We did have the Frederick County Chamber of Commerce was represented, but I think that's a great point, and there's that would be a good group for this outreach to be targeted towards if we're thinking about that campaign.
Thank you. Any other questions for the sponsor and her witnesses? Seeing none, thank you very much, Delegate. So next, Vincent DeMarco is not here, is that correct? Correct. Okay, thank you. Next, we have Mr. Kenneth Phelps.
Thank you, Madam Chair. If I may be indulged, just a point of personal privilege. If I may, I just wanted to say I'd be remiss if I did not say what an honor and privilege it is to once again be in the presence of the Honorable Jamila Woods. Long time no see, but great to be with you.
Yeah, sure.
Thank you, ma'am. Thank you.
My pleasure.
As stated earlier, I am Ken Phelps. I represent the Diocese of Maryland. And as my brother Lee Hudson pointed out, as is his case, the Diocese of Maryland, but not just the diocese, the Episcopal Church, USA, has declared that health care, along with education, shelter, and healthy environment, are all human rights. And as is the case with health care, in that case, it was something Jesus gave away. We talked about him when I was up here earlier. We believe it should be accessible, of high quality, and universal, available to all, since again, Jesus gave it away as gift, as a right. So when I left off, we talked about eternal life, authentic life. I want to talk about corporate sin. We brought that up, which in the traditions of the prophets is corporate. You see, as I challenged you earlier, you not only have the ability to help us be more authentic, you can also take us, a step closer to redemption corporately. Because our corporate sin is that we have put a price on everything. I like to remind us that when Jesus came to his capital, the first thing he did was go to the center of power and toss out all the capitalists. I'm just saying. And in our pursuit of profits, we have commodified the basic necessities of life, health, education, all of these things, making optimum health in this instance a luxury for those who can afford it. And this bill may not seem like much, but it's one more small step in moving us toward that universal part of health care, a small step to making it more affordable to more people. And we need those small steps, just as we need the larger conversation about why change cannot come faster and about our addiction to profit for a few at the expense of many. And in that spirit, I want to say the Church applauds your work, expanding in this last decade, as Delegate Lewis pointed out, care to a growing number of Marylanders. Keep up the good work, and we do request a favorable report. Thank you, Madam Chair.
Thank you for your testimony. Any questions? Hold on a second.
Oh, sorry.
It's okay. Any questions for this witness? Seeing none, thank you for your time. Really
Thank you.
appreciate it. I would like to call the following people to the panel. Sarah Jones-Smith, Bryson Puffin, Brett Lininger, Allison Taylor, Matthew Santillano, and John Andrzejak.
Thank you, Madam Chair. With your permission, I'll begin.
Yes.
My name is Bryson Popham. I'm here today on behalf of the Maryland Association of Health Underwriters, which is a trade association of several hundred brokers and consultants who offer health insurance to Maryland citizens throughout the state. We are here in support of the bill with the amendment offered by the sponsor. This bill, it might interest the committee to know, started differently last year. It was a small group subsidy bill, and it sought to provide subsidies to the small group market in the same manner as we provide them to individual insureds. That's an apple and an orange from a tax law standpoint. So what happened was the bill turned into a study. We had a task force. I'm pleased to say that a member of our association, John Frank, was the co-chair of that task force. The task force did very good work, and the result, I commend the sponsor, is the bill that is before you today. One of the earlier witnesses characterized this bill as a communications device. Respectfully, I would amend that to hope that it is a very effective communications device. For as long as I've been around, we have been trying to get more and more Marylanders insured. My clients have always striven to do their part in that effort. They did so on this bill. They were pleased and honored to do that. And for that reason, again, with the amendment offered by Delegate Lewis, we would respectfully request a favorable report on House Bill 107.
Thank you very much. Who's next?
Thank you, Madam Chair, members of the committee. Brett Leininger here on behalf of the National Association of Insurance and Financial Advisors. Glenn Arrington, who is our president-elect of the Board of Directors, also sat on the work group through the interim. He signed up to testify virtually, for whatever reason, did not receive any link to be able to sign up, so he regrets not being able to speak, but just wanted to echo the sentiments that Mr. Popham just announced, and that we are in full support of the bill as it's been amended, and appreciate the opportunity to participate in the work group and to have the conversations with Delegate Lewis's office. Thank you.
You're welcome. And in the future, if there's someone that signs up, just call the office
Will
if there's
do.
a problem, because it'll be taken care of.
Sure
Thank
thing.
you.
Thank you.
Who's next? You're welcome.
Madam Chair. Matt Chilentano here today on behalf of the League of Life and Health Insurers in support of House Bill 107. The amendment that was offered by the sponsor alleviated our concerns. And the only thing I would add is that it might be worth a consideration in subcommittee about aligning the bill or a report with the bill for 2025 when the enhanced subsidies that were passed by Congress would expire. I don't think we want the exchange or others continuing a information campaign around enhanced subsidies if they don't exist. So I think we are supportive of the effort. We were participated in the work group, and we'd like to see this bill move forward. Thank you very much.
Thank you.
Mary Jo Smith will not be testifying. Madam Chair.
I made a mistake, sorry.
Oh, it's not a problem, not a problem. So we have, let me just go through the names so that I know. So Sarah Jones Smith will not be testifying. And then we have Allison Taylor. Okay, wonderful. And then how about John Andrzejak? Okay, wonderful. I love this. Okay, so are there any questions for these witnesses? Thank you so much, and thank you for working with the sponsor. We really welcome that in this committee. It's welcome, and also your participation in subcommittee. Thank you. I have 2 virtual oral testimonies, so if you will be so kind and patient while we pull them up. They're not? So Dr. Tamara Green is not there, and Glenn Arrington is not there. There's no one in the waiting room. Okay, for the next bill hearing. Okay, wonderful. So actually, this concludes the bill hearing on House Bill 107. And now we are on to the last bill hearing of the day. That is House Bill 305. And that will be Delegate Kurt. And will you be so kind, Delegate Kurt, and bring your panel with you? And that is Health Insurance Utilization Review Revisions. And I want to welcome former Chair Pete Hammond. Pete, thank you so much. And I have a lot of respect for my former chair because he taught me a lot. So thank you very much. And whatever I'm not doing that is wrong, you blame it on him, okay? Delegate Kerr.
Thank you, Madam Chair. I promised not to make it a habit of being the last bill of the day, and by way of
I think you owe us food by now. You really do.
well, by way of compensation, how about if I take you all out to Osteria tonight for dinner?
You are so generous. Go ahead. I know you were a musician, but not a joker, but go ahead.
It's really the least I can do.
Okay.
So, thank you,
You can
everyone.
get started.
Thank you.
My pleasure.
Well, good afternoon, or possibly evening by now, Madam Chair. I'm Delegate Ken Kerr. I'm here tonight with House Bill 305, Health Insurance Utilization Review Revisions. Before I begin, let me make 2 points. First, the bill does not do away with prior authorization or other utilization review techniques. Rather, it tries to make a more balanced approach for both practitioners, for both patients and physicians, by attempting to reduce the volume that's subject to prior authorization, by increasing transparency and communication, and by studying how the process can be improved overall. Second, we have over 50 organizations representing healthcare providers and patient advocacy organizations supporting this legislation. Today, you're going to hear some common stories from physicians and others in the field of oncology, gastrology, rheumatology, primary care, pediatrics, psychiatry, and more, which will indicate that this is a systemic issue across the entire spectrum of healthcare. We heard earlier this session from the Maryland Insurance Administration. In 2021, health insurance carriers rendered 81,143 adverse decisions or denials. This was an increase from 78,314 in 2018. And the 3 areas that receive the highest volume of denials are pharmacy, dental, and then the combined category of labs and radiology. In addition to the increased denials, the MIA also told us that when consumers file a complaint with the MIA, the patient ultimately benefits from the outcome. In 2018, the carrier's denial was modified or reversed 67% of the time. By 2022, this percentage increased to 72.4% of the time. And these reversals resulted in more benefits for Maryland consumers, benefits that they could have and should have arguably been given to the patient at the first request. To me, these numbers indicate a problem. Reversals or modifications by the MIA should be the minority of the cases, not the majority. Not only are patients affected, but physicians and healthcare providers are also negatively impacted, resulting in increased costs and burnout. The American Medical Association conducted a study back in 2021 and found that 40% of physicians have staff that work exclusively on prior authorization requests. The survey also found that on average, almost 2 business days a week are spent completing prior authorizations. Again, both time and money that should be spent on patient care. Therefore, House Bill 305 will reduce the volume of medications subject to prior authorization. First, it will allow a patient to stay on a prescribed drug without another prior authorization if the insurer previously approved the drug and the patient continues to be successful. Too often, as you will hear in today's stories, patients suffer or were at greater risk of medical complications because their carrier denied their current drug on reauthorization. Second, House Bill 305 will exempt drugs from prior authorization for dosage changes, providing that the change is consistent with FDA guidelines. Third, it will eliminate prior authorizations for generic drugs or incidences where there's a need for multiple prescriptions due to formulation differences. House Bill 305 will also increase transparency and communication, which will hopefully save time for providers, patients, and the insurance carriers. A few key provisions are House Bill 305 will require that the physician making or involved in making a denial is knowledgeable of and has experience in the diagnosis and treatment under review. House Bill 305 will require that carriers reach out to the treating provider prior to issuing the denial and not just be available for a discussion on the medical necessity. Delays can negatively impact treatment plans and schedules. House Bill 305 will also require that the physician or the dentist making the denial has a current valid Maryland medical license. Maryland doesn't allow an individual to treat patients within the state without a license, so why should we allow them to deny treatment to a Maryland patient without a Maryland license? Lastly, House Bill 305 contains 2 studies that aim to make the process more efficient. The first study is the feasibility of implementing a gold card standard in Maryland, which would exempt healthcare practitioners who meet certain criteria from prior authorization standards. Second is a study how to create better standardization, uniformity across the electronic prior authorization system to make them more user-friendly. This study authorizes CRISP to conduct a pilot program to create a single entry portal rather than each carrier having its own portal. So I realize that insurers and the PBMs oppose this legislation. And since the bill was dropped, I have met with just about all stakeholders individually. And earlier this week, we met as a group to see where we could find common ground, where we were still far apart. We really all want to work together to create meaningful reforms. And now I'd like you to hear from my panel.
Who would you like to be next?
I will. Thank you, Madam Chair, members of the House Health and Government Operations Committee. My name is Dana Kaufman, and I'm here today on behalf of MedChi and several other healthcare clients. Today, you heard several bills whose purpose is to extend coverage to Maryland residents. But it's important to note that coverage does not mean access to healthcare services when they are needed most. And that is really the issue that we have before us today, the ability to have those healthcare services when patients need them most. This is not the first time that we've been before this committee on prior authorization. In 2019, there was legislation introduced and passed, and in that legislation, it actually tackled two of those issues that are again before you. The issue of dosage changes and a patient having to get a reauthorization. For the dosage changes, the bill actually said that a carrier has to honor a prior authorization when there's a dosage change. But however, we are still continuing to have to submit those requests, which is taking staff time. As far as the issue regarding the reauthorization, the bill initially came in as to say that you didn't need a reauthorization. It was opposed, so the compromise was 1 year. We're back before you now. I don't know of any issues that arise from reducing the multiple issues to 1 year or the multiple reauthorizations to 1 year, but I can tell you now, and what you're going to hear is on reauthorization, these patients are being denied the medication that has maintained their treatment and their condition. So we are asking for that now to require that to be under prior authorization. I know this bill looks long, but it really does. We did it judiciously. We really did plan on what we can do now and what we may do later. We are willing to work on this, but we need to make changes now. The physicians are overwhelmed and the patients need their medication and their treatment. Thank you very much.
Thank you. Go ahead.
Good afternoon. My name is Angela Campbell, and I'm the supervisor for the Prior Authorization Department in the Cancer Institute at GBMC. We have 10 providers in the practice specializing in oncology and hematology. To support these providers, we employ 5 full-time staff who obtain prior authorizations. Over the years, we've seen the process grow more cumbersome with more treatments requiring authorizations. Each day, my staff and I submit on average 50 requests through the electronic prior authorization systems used by carriers. I can assure you it's not an easy process, and the solution to addressing denials and delays is not for physicians to simply use these systems. These systems are often part of the problem. There's no single portal or uniformity among the electronic prior authorization systems. While there may be some overlap in vendors, each carrier has its own portal for submission of requests. Within one carrier's portal, there may be additional portals for specific types of authorizations, such as oncology or cardiology. Often it feels that we're sent in circles trying to get to the correct portal. When we submit an authorization request, the required information is different for each portal and often is not relevant to the patient's diagnosis, which takes additional staff time to complete. Only about 50% of authorization requests are automatically approved. The remaining requests are denied or pended for additional information. Because the portals don't interface with our EHR, when medical records are requested, these records must be printed, scanned, then uploaded to the portal or faxed depending on the carrier. Often authorizations will be denied or delayed due to missing information. Most of the time, this information was already submitted, but the carrier staff are not familiar with reading our records, which then requires a series of phone calls between us and the carrier, and this takes considerable staff time. To conclude, the most frustrating aspect of this process is that most of the time our authorization requests are ultimately approved, but only after considerable staff time is spent working through the process, which can take days or even weeks, causing patients stress and anxiety, especially when it affects the timing of their treatment. Thank you for listening, and I hope that you act favorably on this legislation.
Thank you. Who's next?
Madam Chair, members of the committee, my name is Dr. Carolyn O'Connor. I'm a family physician in Rockville, in practice for over 30 years. I'm going to tell you a sad story about a patient of mine who was in her early 60s. She had COPD, which is a serious lung condition. During the summer of 2020, she was experiencing an exacerbation, called 911, had a respiratory arrest in the ambulance, and ended up in the ICU on a ventilator for a time. When she came out, it was realized that her current regimen wasn't working, and she was changed to something that was a little more expensive that required prior authorization. Because of a recent disaster, the medication went through the authorization process and she was prior authed. Come around to the fall of 2021, it's an annual renewal. It took weeks of effort on the part of my office and her pulmonary doctor's office to reauthorize the same medicine. Happened, got it done. Come around to fall of 2022. Again, weeks spent trying to authorize the same medicine. I get a notification that my patient had passed away. I talked to her daughter. She said that her mom had been having to spread the doses of her medicine because it hadn't been authorized yet. She was home alone, had an exacerbation, and this time did not make it to call. Her daughter came home to a dark house and found her mother on the bed with the phone next to her, not having been able to call 911, and she passed away. And I laid this at the feet of the process for prior authorization. Thank you so much for hearing my story, and I could answer any questions if you have them. Thank you for your time, and I support House Bill 305.
Thank you for sharing the story, and thank you for for your work. Thank you. Who's next?
No, don't touch it.
Yeah, do not touch them, please.
Sorry.
I want $1 for every time I say that. Go ahead.
It says it right there. I'm Paul Solano, the president of the Maryland DC Society of Clinical Oncology. I'm a practicing medical oncologist here in Maryland for over 30 years. I serve as the medical director of cancer services at the Greater Baltimore Medical Center in Towson. I also would like to offer a few examples of patients that have been snatched up in the current process that impacts the care of our cancer patients. One is a 67-year-old male who had metastatic kidney cancer to his lungs and abdomen. We requested a Category 1 standard of care treatment for this patient to be expedited. The authorization staff attempted to have this authorized through the insurer. They were turned over to the insurer's oncology authorization vendor. The online portal stated that authorization could not be obtained through the portal system, and we had to call the insurer directly. This was then passed around in circles between the insurer and the insurer authorization vendor, eventually talking to 6 different people. Eventually, we were told to fill out some forms. They were faxed. We went to call the next day. They could not confirm that they were that they had been received. They received additional. We sent additional information, and then finally, ironically, we were told by the insurer that the authorization wasn't even required. This whole process took over 8 days. Eventually, this patient was hospitalized for their condition. Another is a 46-year-old woman with triple-negative breast cancer, very aggressive type. Standard of care chemotherapy was offered. The drugs that were required were denied. There was a peer-to-peer requested. Finally, we were called back by a pharmacist. The pharmacist said, oh no, you need to talk to an oncology-specific provider. We were told by the insurance carrier there is no such person. After several hours back and forth, we spoke to the appeals staff. We sent additional information in writing to the insurer. Well,
You can finish your thought. Go ahead.
right. Ultimately, it took over nearly 18 days for this to be authorized, and I just greatly would appreciate the support of this bill. Thank you so much.
You're welcome.
Good afternoon, Madam Chairwoman and staff committee. My name is Dr. James Chesley. I'm a gastroenterologist, been practicing in Prince George's County since 1984. I want to take my time to support this bill and give you a vignette of a case history of a patient recently taken care of, and many are like this. Had a 24-year-old female who was referred to me by her primary care physician for abdominal pain, diarrhea, alternating with constipation and weight loss. He had been treating her for a while, thinking that was probably due to her senior year at college here, and that she was stressed with the exams and getting ready to go out on her own, going to leave home, first time out, and applying for a job. After his treatment did not work, she was referred in to me. I saw her, got authorization for a colonoscopy. This was performed, and lo and behold, it showed what I thought. She had inflammatory bowel disease, Crohn's disease of her small intestine. Whereupon I prescribed medication for her, which then was promptly denied. We went through this for 13 weeks. 13 weeks that this young lady had to suffer through this, still with the same pain. Once we got things certified, she got the medication, and within 10 days was dramatically improved. Abdominal pain resolved, the diarrhea and the constipation alternating dissolved, and she started gaining weight. She gained all of her weight back, went out on interviews, got a job, was gainfully employed, moved out from her parents, and doing quite well. Well, as many of you may know, we can get medications for a 3-month period of time and have to keep repeating them. Well, on the time for her year time for renewal, it was denied. We waited another 5 weeks to get her medications. After 2 weeks, she started with the symptoms again. Diarrhea, abdominal pain, constipation, got so bad she had to return back home. She lost her job. Eventually, we were able to get the medicines done, and we got them returned in. After 5 weeks this time, did not take as long, and she was able to get started back again, did well, started gaining her weight, the abdominal pain resolved, once again the diarrhea and constipation resolved, and she was able to go ahead and get a job because she's a bright young lady, very, very enthusiastic, and started returning. And I'd like to conclude by saying that we were very fortunate in then reinstituting her medication. She didn't get an antibody response because when you stop medicines like that, sometimes the body will reject the medicine being reinstituted. We also were quite fortunate that we had the time to go through this authorization process. We also were quite fortunate that I was following the standard of care and those authorization people were not. They were looking at 2010 data, not the 2022 data. If this had been a physician treating something like this would have been malpractice. Thank you.
Thank you. You'll see that some of our members are coming in and out. They have hearings in other committees, okay? But we're certainly paying attention. Delegate Kerr, will you be so kind and come up? I'm going to open it up for questions now. Are there any questions for Delegate Kerr and his panel? I'm going to start with Delegate Johnson, followed by Delegate Lewis.
Thank you, Madam Chair. Dana, can you address the changes this bill is making on the review standards used by insurers?
Yes. Thank you very much. So what our bill is doing, or what Delegate Kerr's bill is doing, is it is, right now, Maryland's law only states that the utilization criteria have to be objective, clinically valid, compatible, and with established principles and flexible enough for deviations. But it doesn't say how are they basing that on, what are they basing that on. And the concern, and I've actually heard the expression here, homegrown. When they turn these into the MIA has said that they do not have clinicians that are reviewing these. So what our bill is trying to do, or the bill does, is it says that those standards that are being reviewed for medical necessity, and that's again what we're looking at is medical necessity, has to be based on accepted standards of care developed by the appropriate specialty society. This is not a new concept in Maryland's law. There's already 2 incidences where that language is based on, or the review standards is based on a specialty society. For example, when determining medical necessity for hospital services related to maternal and newborn care, Maryland law requires that criteria to be based on criteria developed by the American Academy of Pediatrics and the American College of OBGYN. And for substance use disorders, there's a reference in the statute that it has to be based on the American Society for Addiction Medicine. So we believe that if you're going to be using standards, then one, they need to be acceptable and clear, and that they also have to be given to the physicians or healthcare practitioners on a denial, so that we know exactly what the basis was. So those are 2 of the changes dealing with the standards. Thank you.
My pleasure. Delegate Lewis, followed by Collison, followed by Hill.
Thank you, Madam Chair. Thank you, Delegate Kerr, for bringing this bill. I do realize it's complex and there are lots of moving parts and lots of perspectives. There is a significant opposition to the bill. You mentioned that you've had conversations with all parties, all stakeholders, and you're ready to come to the table. Can you describe what kinds of alterations have been raised and what has been discussed with the opposition?
Delegate Lewis, we've identified areas that we think we can make some progress on this year, and we've also identified some areas where we think, as you said, there are some complexities that we're going to have to study over time. I can't say that we've reached a full agreement on anything that I would like to pin anyone down as saying that we've reached agreement on some things. So, but it was a very good conversation, series of conversations, and I'm confident we'll be able to get something done this session and then get the complicated parts sorted out over a period of time.
Thank you. Thank you, Madam Chair.
My pleasure. Delegate Collison.
Thank you, Madam Chair. And this question is for one of the doctors. First of all, let me say your individual experiences with some of these patients is compelling. So thank you for sharing those stories. I'm wondering, when I go to physicians, they generally come into my room or into the room with a computer, and literally, they say they're going to give me a drug, and literally before I leave that room, 2 minutes later, the drug is approved. And I guess maybe they just have access to something that is much more quickly administered or administrated. I understand there's something called real-time benefits, a real-time benefit tracker or something. Is that something you all are familiar with, and is it something that you use? Okay.
Who's the best person to respond? Okay.
So we do use real-time eligibility at our place of employment at Greater Baltimore Medical Center, but basically it only tells you about a patient. Are they eligible for their insurance? What is their benefit? What is their copay? Do they have a deductible? Do they have an out-of-pocket maximum? Where are they in those things? What are their accumulations? That's what the real-time eligibility does for us as an organization, but it does not obtain or help with prior authorizations.
May I follow up?
Follow up.
Is there a link on that form to the appropriate portal?
No, there is not.
There is not. Okay. Thank you very much.
Delegate Hill.
Thank you. I don't even know where to begin because I only get one question.
I'm going to give you 2 if you ask them really fast.
All right, thank you. So let me start with you, Dana. So this is not your first foray into pre-authorization. We did this dance 4 years ago with a study and with a very compromised bill. Why is that not working? That was supposed to make a difference. It was supposed to cut down on the amount of time physicians have to spend advocating for their patients as the people who actually see them in the room and make the diagnosis and come up with the plan, that they're constantly being second-guessed by insurers who the majority of the time come back around and say, well, I guess you were right, doc. So we worked out a lot of stuff then. You're a professional. Why is this not working?
So I think I will respond in 2 ways. So the initial bill back in 2019, and you're right, it was a bill in 2018. We had a work group. We didn't reach any consensus during the work group time, but when we came back in 2019, we did have compromised amendments that we worked out. But one of those amendments did say that an entity, and I was reading it before, an entity shall honor a prior authorization for dosage changes that are consistent with FDA labeling. However, that's not the case, and we are still seeing dosage changes going on. So I can't say why, but I know that the bill that is before you has drafted to say that a carrier may not require. So we flipped it around, so maybe there was confusion, but we made it very, very certain. As far as the other issue and why we are still here, it is interesting because before it was opposed because, you couldn't do away with reauthorizations for the medication. So we got rid of the multi-steps or the multi-times in 1 year, and we said, okay, we'll only do it 1 year. But we're back because, as you've heard, on the 1 year we're getting denied, and it's the same medicine, the same condition. But unfortunately, we are still seeing denials. I can't tell you why, but if I am treating a patient with the same condition on the same medication, where they may have tried others and not been successful, because as you know, as a physician, not every patient is going to respond the same way, it does not seem rational to require them to always have to go through a reauthorization.
Yes.
So I was going to ask the doctors, part of the problem is we don't have anything in law that says if a delay in authorizing medication that the physician has prescribed could make the insurer liable.
I would imagine that if a insurer would be liable for the decisions that they're making and that the denials that they're making, I would imagine that they would have a lot less denials and delays. So medical necessity is the care necessary. That is a medical decision, and they are making medical decisions, but they are not held to the same standards as the doctors you have before you today.
Thank you. Are there any other questions? Can I ask you, is there a role for MIA? Because I know that if you're in a hospital and then there's a denial of some test, you can call MIA and within like 24 hours they get involved. Is there at all a role for the Maryland Insurance Administration in these instances where it's a Friday, right, and you really need it and there's a weekend? Just asking.
Yeah, I mean, so right now the current law does have under the appeals and grievance, if it's an emergency case, the MIA, they can step in, but it's still a difficult process. But I think what we're seeing more is the fact that we have these delays where the patient either has a bad outcome, or the longer it's delayed, then the patient continues to decline, and may not have been a true emergency on day 1 of the ask. By day 21 is now an emergency. But there is a provision in the bill. It's just education, but I think it's vitally important so people know that they have alternatives of appealing decisions. That the law that is on the books passed in, I think it was in 2010, we haven't updated it, and I think we really do need to educate everybody involved that there are processes that can be put in place when situations like this occur.
And I know that you're at the table because I have spoken to many of you and also to Delegate Kerr. If you do come to a compromise, some things that you're able to do this year, right, and work in the interim to look at the other outstanding issues, I like to see something in the bill where MIA can keep track of how many of these complaints perhaps, and for MedChi to let their docs know to start calling MIA just to see, if how fast it works, or because I hear that it's prevalent, right?
Mm-hmm. And if I may, there is a provision in the bill that amends the information that has to be included in the appeals and grievance on prior authorization. Off the top of my head, I can't remember each one of the provisions that we added, but to really try to get more information. And also, there's a provision that tries to put a little bit more teeth in the bill to require that the MIA is really looking at, because they do the report now, but then what happens with the report? Really nothing. It's great information, but that there is an enforcement mechanisms if the laws are not being followed. So we tried to do that as well.
Thank you. Thank you for your work on this and for your testimony. Any other questions for this panel? Seeing none, thank you so much. I appreciate it. We have, if I may have the following people next, please. Aaron Morey, and forgive me if I mispronounce your name. Daniel Dorothy, and Rouse? Oh, okay. I'll get rid of her. Michael Patty. Robert Herman. And Daniel Shutter. You can get started.
Okay. Good afternoon, Madam Chair and committee members. I'm Dr. Aaron Morey. I'm a rheumatologist in Anne Arundel County and a member of MedChi, and I'm here in support of SB 308, or sorry, HB 305. Sorry about that.
It's okay. It's been a long day.
It has, yeah. Imagine that your asthma is acting up and you have to wait for prior authorization for prednisone, which is a $5 generic drug. If you don't get it in time, you could end up in the emergency room or worse. I've had prior authorization requests for prednisone because it's labeled as a transplant drug by the carrier. This is true, but it is also standard practice to use prednisone for acute asthma, serious flare-ups of lupus, and the delay in prednisone for lupus flare-ups like asthma can result in ER visits and hospitalizations, costing the system substantially more than $5. HB 305 exempts generic drugs from prior authorization. Likewise, dose changes within FDA guidelines should be exempt from prior auth. If a patient is on a drug like Humira that is already authorized, why does my staff have to spend time getting another authorization just to increase to a higher FDA-approved dose? This takes time away from patient care, such as chronic care management, which also reduces or prevents ER and hospitalization visits. When carriers, if the carriers say that that utilization review protects patients, then why are 70% of prior auths overturned when a complaint is filed with the MIA? During the thick of the pandemic, I had a psoriatic arthritis patient who was prescribed Otezla, which is a drug that doesn't suppress the immune system. Her carrier denied this drug. This patient was older, obese, diabetic with heart disease during the pandemic. So I don't understand why they denied this drug. They denied it in favor of an immune suppressive drug, which has much more serious side effects, which would have put her at increased risk for severe disease or death from COVID. The decision by the carrier in this case did not protect the patient. Instead, it went against common sense and psoriatic arthritis treatment guidelines. This House bill will require utilization review to be guided by specialists in the field. This bill will improve appropriate, timely, evidence-based care and free my staff to provide chronic care management, which will prevent ER visits and hospitalizations of my patients who have serious diseases who are immune compromised. Thank you for your time.
Thank you. Mr. Doherty?
Thank you, Madam Chair, members of the committee. I'm Dan Doherty. I'm here on behalf of the Maryland State Dental Association and the Maryland Society of Oral and Maxillofacial Surgeons. Let me, as my first point, emphasize something that the sponsor indicated. In the report of the MIA on the Appeal and Grievance Law, which was filed in November of 2022, it looked back over the years of 2018 and 2021. In both years, dentistry was second in the number of denials, which is pretty amazing when you look at the number of dentists population versus physicians. It did go down in terms of numbers in 2021 from 2018, when it was almost a third in 2018. But the reason for that was COVID. Dental offices were closed for a period of time, and then once they reopened, patients only wanted to come in for true emergencies. So the number of encounters were down, the number of requests for prior authorization were down, and that's the reason for that difference. It's interesting to note in that report that 7 of 10 complaints of denials that were filed, the decision was reversed. This has a big impact on the patient, has a big impact on the dental office. Many dentists employ 1 or 2 full-time employees to handle these requests for prior authorization and trying to get coverage for the procedures that are deemed dentally necessary. And this is not an easy thing to do. You have to really have someone who's trained, because they're dealing with multiple portals for different insurers. So they really have to know what they're doing. And finally, I'd like to give you an example. Had a dentist that told me they had a patient that came in, tooth had fractured where there were a number of fillings.
Finish your thought, please.
They requested prior authorization for a crown. It was denied, saying a filling would suffice. They told the insurance company it would fail. They said, do it anyway. Patient is not in a position to wait for weeks to have this done, so they did a filling. Within 6 months, it failed. They resubmitted a claim for a crown, and they said, nope, you can only treat that tooth once in a insured year. So the person was left having to pay either out of pocket or go with a tooth that really needed to be repaired. Thank you very much.
Thank you. Mr. Patty?
Thank you, Madam Chair. Michael Patty, here with Public Policy Partners in support of House Bill 305. You've already heard extensively from the sponsor panel what the bill does, and you've already heard a number of personal stories. So I really just want to direct all your attention to the written testimony that we submitted on behalf of a number of clients. The Maryland affiliate of the American College of Nurse Midwives, the Licensed Clinical Professional Counselors of Maryland, the Maryland Community Health System, the Maryland Nurses Association, the Maryland Occupational Therapy Association, the National Council on Alcoholism and Drug Dependence, the Maryland chapter, the Maryland and DC Society of Addiction Medicine, all submitted written testimony with their personal stories, and I just encourage you to review that. I don't feel the need to take the committee's time tonight to talk about all those stories, but with that, we support House Bill 305. Thank you.
Thank you. Mr. Herman?
Dr. Herman?
Oh, excuse me, Dr. Herman.
Yeah. I'm Robert Herman. I'm a psychiatrist with the Maryland Psychiatric Society. I did submit written testimony that can give you plenty of other stories of horrible things that happen to our patients because of denial of pre-authorization. But I'd like to focus on the testimony yesterday of the opposition of this bill when it was presented in the Senate. I was astonished when I heard what they said. They said that they only were aware of this problem when Delegate Kerr gave them the bill 2 weeks ago, when they've been known of this problem for years and years. Last year, the Maryland Psychiatric Society introduced a bill in the Senate under Senator Reedy, and they came and they listened to our concerns, and they said they were willing to work with us. We've not heard from them since. They said that they need to protect patients from harmful drug interactions. Pharmacists have access to all of the patient's medications, and if they see that there's a concern about interactions, they contact us. They're not needed. They say that their algorithms are designed by teams of doctors who comb medical literature and keep up with the latest advances in medical knowledge. I graduated medical school almost 40 years ago. I've been practicing as a psychiatrist. I tell you that that's not true. They are practice guidelines in every field of medical practice, including psychiatry. We use those to guide our clinical decisions in treating our patients, but we also individualize our treatments based upon the needs and circumstances of the individual patients. The algorithms that the PBMs use have no resemblance to these. We don't need CVS Caremark to tell us how to do our jobs. Thank you.
Thank you, Dr. Herman. And Mr. Shattuck.
Thank you, Madam Chair, members of the committee. My name is Dan Shattuck. I'm here today on behalf of many of our healthcare clients, including the Maryland Dermatologic Association, the Maryland Psychological Association, and also the American Physical Therapy Association Maryland chapter. And you'll hear from a couple witnesses later. I know we've heard a lot today. I just want to echo, I think, a couple of the recurring themes that prior authorization needs to be looked at. There needs to be transparency, some standardization, and accountability. There's also a strong sense of urgency behind this bill, and we've heard it from the patient examples, and we'll hear some more from the virtual testimony. But time is not on the patient's side. You know, if there's administrative delays, if there's prolonged determinations, it really impacts care in a negative way. So what we've put together with this bill is a way to start moving forward, making some changes, making some progress, and I think the sooner we can start, the better off for patients, the better off for the providers. And as you've heard, we've got a broad coalition of support. So thank you for your attention. We look forward to working with you and the stakeholders on this very important bill.
Thank you. Are there questions for this panel? Delegate Shalega.
Thank you, Madam Chair. Thank you all for being here. This is for the physician on the end. I'm sorry, I didn't catch your name. Dr. Maury. So I know back-end costs for physicians' offices is always problematic. It drives up the cost of health care. Do you know how much it costs you to chase these prior authorizations? And then I have one quick question after that, please.
I haven't added it up, but I have, I have two staff members who do prior authorizations, which ends up being approximately one full-time job, and I'm only one physician, although I'm a nurse practitioner, and my other doctor that I hired just got credentialed, so I can't factor him in quite, up until the last month. But yeah, I would like to have, that be maybe a half-time job for the for my office, and have the other staff member doing more chronic care management rather than fielding all of this.
And one quick additional question. Is it, and you don't have to name names, or you can just say yes or no, I don't want to put you on the spot, but is it one carrier that you're continuing to have problems with, or is it just across the board a problem?
It's across the board a problem. I mean, there is one predominant carrier in the state of Maryland, but I see it with all carriers.
Thank you. Delegate Hill, followed by Delegate Kipke.
Thank you. So let me ask Dr. Herman, when you spend time, or your staff spends time doing appeals on authorization, dealing with pharmacists to get temporary other medications in the meantime, do you get reimbursed by the insurance companies for this additional time? Does your fee go up and your coverage go up to, because your time's pretty valuable, right?
No, I don't get reimbursed for that.
Okay, thank you.
Okay, Delegate Kipke.
Thank you, Madam Chairman. Dr. Herman, you had mentioned, you had called out PBM, CVS Caremark. I believe there's like 3 big PBMs. Are they all just as bad in this, or is that one particularly an issue? Thank you.
Are there any other questions? Let me follow up with that, Dr. Herman. Is it the prior authorization goes to the pharmacy benefit manager or to the carrier who manages the plan?
I think it goes to the pharmacy benefit manager. There's a company in Ohio called Cover My Meds that is actually, I think it's funded by the pharmaceutical industry. And then, so there's a digital interface that we do the prior authorization forms that get sent to us. And then it goes to the PBMs, and then they either approve it or they deny it and appeal, et cetera, et cetera.
Thank you very much. Seeing no further questions, thank you very much for your time and your testimony today. And I'd like to call up Thomas Thompson, Louis Tharp, Thomasa Beckett, and Josh Howe. Yes. And James Rice, please. And Dr. Beckett, you want to get started? Okay.
Madam Chair, members of the committee, I'm Dr. Thoma Beckett. I'm a general dentist. I'm the president at the moment of the Maryland State Dental Association Charitable and Educational Foundation, the past president of the Maryland State Dental Association, and a past member of the American Dental Association Council on Dental Benefit Plans. I'm not going to say a lot here. I'm just going to say a lot of me too, but I want to bring a couple of points out. From my time on that council at the ADA, there was always a huge concern. This creates a conflict, not only between the provider and the carriers, but between the provider and the patients, especially when the little paper comes back and says, this is not approved as it's not medically or dentally necessary. That calls into question my training and the training of all my colleagues, both medically and dentally. The other thing I like to say is that I was in private practice for 40 years. I, quote, retired from full-time practice. I spent a lot of my time dealing with administrative matters and issues and cover my good friend's practice when he goes on vacation. But in my private practice, I had 2 full-time employees that covered pre-authorizations and denials and re-denials. And it also created a huge problem that patients got tired of waiting and they just never came back for treatment. And then I'd see them a couple years later and their oral health conditions went way down in that period of time. So with that being said, I would like to thank you and I'd ask for a favorable report on House Bill 305. Thank you.
Madam Chairman, members of the committee, my name is Louis Tharp. I'm commenting on behalf of chronically ill patients in Maryland. I'm from the Global Healthy Living Foundation, the executive director and co-founder. We represent approximately 1 million people in Maryland with chronic disease. I currently live in New York, but I was born in Baltimore. I grew up in Towson, and I have family ties here, so it's good to be back. Thank you for allowing me to comment today in support of House Bill 305. The bill puts the patient first by regulating damaging practices by pharmacy benefit managers and their partners, the health insurers. This increases their profit at the expense of prompt and appropriate patient care. It took 3 months for prior approval of a biologic that I take. I have a chronic disease. My physician staff and I made many calls, completed complicated forms for, again, CVS Caremark, to appeal their rejections. We finally prevailed, but in the meantime, those 12 weeks, I had no treatment. Besides difficulty in obtaining initial prescriptions, patients often can't get timely refills, and passage of 305 fixes this. This is critically important. The renewals start every plan year, and we need to eliminate the common delaying and profit-enhancing tactics of these entities. Patients are the only ones who actually pay for medical care. We pay for this, but we have very little power. The committee is powerful enough to neutralize these bullies, and I mean bullies, with a vote in favor of HB 305 that protects patients and curbs PBM profits that are gained by these delays.
Thank you. Who's next?
And thank you, Madam Chair and members of the committee. Thomas Thompson on behalf of the Maryland Psychiatric Society and the Washington Psychiatric Society. House Bill 305 is a priority bill for these medical associations, and we'll tell you why. This committee in particular, as well as the rest of the legislative body, has done tremendous work, along with the advocates, along with the practitioners, to expand healthcare access to many. We did a lot of work during the interim with regards to, or during COVID, to expand healthcare access. And in the mental health space, it's been meaningful. We're seeing more people, more diverse people. We're getting into neighborhoods that we weren't otherwise in. And now what we have is an insurance authority on patient access as the barrier. Let me say that again, insurance authority on patient access as the barrier. That should not exist. When a patient in the psychiatric world decomposes, where their health goes down, they lose relationships, they lose jobs, they lose sometimes their own life. That's terrible. And that's happening a lot of times because of pre-authorization and the amount of time it takes between when the doctor requests the medication and when their patient actually gets it. We should not be seeing that today at all. You have done yeoman's work to get us to where we are. We can't let a regulated authority by this legislature now stand in the way of meaningful health care. You are not alone in this. Many states are looking at this right now. I know in the past 2 years, Colorado, Georgia, Illinois, Iowa, Michigan, Oregon, Pennsylvania, Texas, all made great strides in changing how prior authorization works in their state. We can make those great strides too. We will work with the other side wholeheartedly. We want a good product at the end because, as you will hear from them, we all have the patient's best interests in mind. I thank you.
Thank you. Next, please.
Please don't touch that. Yeah.
Hi, Jim Rice. I'm a practicing pediatrician right here in Annapolis. I'm here to support the bill because time spent on prior authorizations, excessive time spent, is getting in the way of taking care of kids in our primary care pediatrics practice. We had a surge of viral illness this winter. We have an onslaught of mental health concerns as pediatricians, but we're struggling to meet that demand, and unfortunately, more of our time as physicians and our staff time is spent working through this prior authorization process. In my practice, a pretty large primary care practice, we employ 6 staff members, several of whom are RNs, to do a lot of care management activities, but really each of them every day touch prior authorizations and spend a lot of time dealing with that, often having to get our pediatricians involved as well. The common issues in pediatrics we come up on would be managing asthma, so steroid inhalers used to prevent exacerbations in asthma. A lot of the formularies include only options that kids maybe over 12 could use because they're breath-activated inhalers. So we have to get a prior authorization to use an inhaler that a 2-year-old can use. 2-year-olds have asthma. And I've personally been involved in cases where we've had those meds not covered, a delay in getting those, and have kids end up in the ER. Very frustrating. Another area is ADHD management, falls under our mental health umbrella that we're dealing with in primary care. We had a patient not long ago change insurance. His stimulant medication was not on the formulary and had to try and fail 3 medications before being able to go back to the medication that worked for him. In the meantime, he actually set fire to his bathroom at home and finally got on the med he needed, which did work. And so these delays worsen physical health and mental health. Other areas of difficulty would be in treating infants with reflux, and we have frustrated, tired parents who have to go through this step therapy to get something that works for their infants. And then finally, specialty areas like Synagis to prevent RSV in fragile infants and growth hormone for kids with hormonal deficiencies are big areas of problems for us.
Thank you. Are there any questions for this panel? Delegate Hill.
Thank you, Madam Chair. Dr. Rice, A and B, how often when you put a pre-authorization and it comes up back quickly like, yep, it's approved, do you think, well, thank God I went through that process, to be sure that what I was doing is right? And how often when you get a denial, do you end up saying, glad they caught me because they're right, there was a better medication that I should have prescribed?
I wouldn't prescribe that way, right? I mean, these are the meds that are evidence-based practice to use these medications, and really standard of care is what we follow.
The denial is leading you to no choice, not because you
Correct.
think what they're leading you to is a better choice.
That's right.
Thank you.
Any other questions? Seeing none, thank you very much for sharing your experiences with us. We really appreciate it. Josh Howe? Is Josh Howe here? No? Okay. David Sharp, and I'm going to call a few people that are favorable with amendment, and Ellen Weber.
Would you like me to begin?
Yes, please.
Very good. Good afternoon, Chair Pena-Melnick and members of the committee. For the record, my name is David Sharp. I'm the Director for the Center for Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission. It's my pleasure to present testimony on behalf of our Executive Director this evening, Mr. Ben Steffen, who could not be here today and sends his regards. The bill requires the Commission, in consultation with providers, payers, and the state-designated health information exchange, to develop recommendations to achieve greater standardization and uniformity across payers to ease the burden of pre-authorization and other utilization management techniques for patient providers and payers. The bill also requires the Commission, in consultation with the Maryland Insurance Administration, to study the development of standards for the implementation of payer programs to modify pre-authorization requirements for prescription drugs, medical care, and other services based on provider-specific criteria. The Commission supports House Bill 305 with amendments to extend the study time to adequately complete the work and assess the potential impact on pending legislation at the federal level on prior authorization. On December 13, 2022, the Centers for Medicare and Medicaid Services released a proposed rule that aims to streamline processes related to prior authorization. The Commission also notes that more time is needed by payers to consider the impact on the existing prior authorization process and technology systems. The Commission encourages stakeholders to continue to collaborate on select issues in the bill, Section 1, as the bill advances. The Commission's work group process, an element of study activities, is an option for addressing certain unresolved matters. We hope this information is helpful and encourage a favorable report on HB 305 with the proposed amendments. Thank you, Chair Pena-Melnick, for the opportunity to testify on the bill.
Our pleasure. Are there any questions for Mr. Sharp from the committee? Seeing none, thank you so much for being here today.
Thank you.
Will you please get started?
Yes, thank you very much for the opportunity to testify in favor of HB 305 with amendments. I'm Ellen Weber with the Legal Action Center. We convene the Maryland Parity Coalition, whose mission is to expand access to mental health and substance use disorder care through the enforcement of the Mental Health Parity and Addiction Equity Act. My testimony today is going to focus on the utilization review requirements. As you've already heard, those practices make the difference between whether somebody gets timely access to care or not. So we offer several amendments which are attached to the testimony to both strengthen consumer protections and to reduce the administrative barriers on practitioners. First, as Ms. Kaufman has noted, Maryland law already requires health plans to use the American Society of Addiction Medicine criteria for all substance use disorder UR decisions. HB 305 would not alter that requirement, and our proposed amendments clarify that. Second, as Dr. Herman has indicated, standardized evidence-based criteria also exist for mental health care, but the state doesn't yet require that they be used in a mandated way. But to ensure that those standards are used, we offer some amendments to strengthen both the source and the content of the UR criteria. First, to ensure that uniform UR criteria are used across all health plans, the bill should require carriers to use criteria that are consistent with generally accepted standards of care, and our amendments would define that term. Other states use that term in that practice. Additionally, those criteria, the carrier should be used to use criteria that are actually developed by the nonprofit professional clinical specialty for the relevant condition. They are the experts, and they have absolutely no financial stake in as the criteria are applied to the patient's case. And finally, in addition to having the right UR criteria, there have to be formal checks to ensure that carriers are actually using the standards they say that they're using. Like Chair Pena Melnick has indicated, we think the MIA has a distinct role in this. Carriers should be required to demonstrate that they use those criteria. And if I may continue just one more minute, or one more second, really. On a patient level, we also believe that before the carrier issues a denial, in that conversation that they have with the provider, they should be demonstrating that the care that they are denying does not comply with the UR criteria. That's the burden that should be on them. Thank you very much. We appreciate a favorable report with amendments.
Are there any questions for this witness? Seeing none, thank you. Oh, yes, Delegate Lewis.
Thank you, Madam Chair. Thank you, Ms. Weber. I actually read your testimony, and it makes me want to ask you a question. So I heard, I had to get my thoughts together.
It's okay.
I
it's
heard
been a long day. Go for it.
Thank you. I have heard that these utilization review teams process hundreds and hundreds of pages of new medical and clinical discoveries and recommendations. They read all the literature, which is voluminous and accelerating in volume because we learn more every day. But that somehow these teams that are hired by PBMs, I guess, are able to process all of this new information and make recommendations and judge whether clinicians are making the right decisions. And I'm trying to understand how those teams who are paid are better judges of utilization decisions than clinicians and these nonprofit assessment teams you're referring to. How is it possible? Because I think we're talking about human beings, not chat GT or any kind of AI programs. These are human beings processing information, making decisions. How are these? What's the justification for the difference between these?
So I think you're absolutely right, Delegate Lewis, and thank you for the question. I think the reason we are recommending that that this bill be amended to require that carriers use the criteria for the nonprofit specialist society is because those are the experts, and they are the ones who also have the time to take a look at all the medical literature, and then they revise their standards as needed. I'm not a clinician, I'm not a practitioner, but it's my understanding that those are the criteria that the clinicians use and actually have on their systems as they're seeing patients. And as we've already heard from testimony, they follow those criteria and then they tweak it to the extent there's an individual need from that individual patient. We all know that's the way medical care should be delivered. It's the physician or the practitioner in the same room talking to their patient, and they know that patient. If we had that particular, if that were the standard that was applied and that all carriers followed that, then regardless of which insurance I have, my clinical condition would be treated the same. I wouldn't have to worry that one carrier will give me one type of treatment based on their criteria, which are proprietary and very often, and another carrier would require a different kind of treatment. These are all the same conditions with individual variations. There should be the same clinical standard, and that's what the Nonprofit Society of Clinical Practice delivers and offers.
My pleasure. Any other questions for this witness? Seeing none, thank you. You want to turn your light off, Delegate Lewis? Thank you very much. So next we have a panel of unfavorable, and I'm going to call about 5 of you first. I have Deborah Ripken, Matthew Centellano, Heather Casconi, Camille Fesh. No? Okay. That's it. Who would like to get started?
Evening, Madam Chair. My
Yes.
name is Matt Chilentano. I am here today on behalf of the League of Life and Health Insurers, the Alliance of Maryland Dental Plans, and AHIP, America's Health Insurance Plans, in respectful opposition to House Bill 305 as introduced. First and foremost, as you've heard before, we are very much willing to engage on this issue and on this bill, and we'll be able to table to work on it this session and beyond if needed, if this committee sees fit. There are certainly parts of the prior authorization statute that have not been updated in a significant amount of time. And what in front of you, we believe, is a drastic step all at once. You'll see, I think, in the fiscal note that this could have extreme cost implications in the state plan and the commercial market as well. And I think it requires a proper amount of time to think it through. We know from many of you have heard that from physicians that this legislation, or about this legislation and how prior auth limits their ability to serve their patients. But from our end, we think it's important for you to hear that prior authorization is fundamentally care coordination. That's the basics of it. It's a layer of consumer protection that keeps them safe, but also helps control skyrocketing healthcare costs. You guys hear us talk about cost all the time and how we need to continue to try to keep healthcare affordable. There was an NIH study from a few years ago that surveyed over 2,100 physicians from the American Medical Association master file. The survey indicated or inquired about the extent of overutilization, as well as causes, solutions, and implications of healthcare. The survey found from physicians, their own study of themselves, that a median of 21% of overall medical care was unnecessary, including 22% of prescription medications and 25% of tests, along with 12% of the procedures. This is a problem that addresses all of us. Delegate Lewis talked about the time frame it takes for doctors to stay on top of medical knowledge. We understand that, but we want to be a part of a team that addresses the medical care. Doctors obviously care about their patients, but so do we. They're our beneficiaries, and we want to make sure that they're not only safe, but they get the most cost-effective care possible. We will continue to be at the table, and we ask for an unfavorable report on the bill as introduced. Thank you.
Next, please.
Hi, Madam Chair, members of the committee. I'm Debbie Rivkin, Vice President of Government Affairs for Care First Blue Cross Blue Shield. In opposition to this bill as drafted, but very much willing to try to improve the process. I would say that the wholesale changes in this bill are not appropriate, but that doesn't mean we can't do something. Spoken to the sponsor of the bill, spoken to the advocates on the bill, and we'll continue to work on trying to come up with a creative, reasonable solution to this. But when I look at this bill, I see two things. There is the pre-auth process, and then there is the appeals and grievance process. And I can explain both if I need to, because I won't have time. And in the pre-auth process, what this bill does is it takes complete pieces out of us to do a pre-auth. Again, I don't think that's appropriate, and I can explain why. Secondly, for the appeals and grievance, that's all the time frames in the bill. It's once something's been disapproved, then it comes into the carrier and say, let's work on the process to try to get it approved, give us additional information. Those timeframes I think we can work on. I think it's absolutely reasonable. But I think you got to get the right people in the room. We got to get the medical directors, we got to get the providers, and I got to get our teams in here who actually are making these decisions and getting the letters out to find out reasonable times. But I think we can do that. The other thing I want to talk about now, I'm going to move really quickly to the pre-auth piece. My recommendation is looking at what Virginia just did. Virginia took a year, they pulled in 21 different stakeholders, including regulators and everyone under the sun in all different points of view, and they came up with a bill that they introduced this year that's just about ready to pass. And what that bill did is says that carriers and providers need to start using the electronic health record processes with real-time benefit check. I'll talk about that more when I can, because I'm going to have time up, but I'd like to be able to explain more to you about what that all means. And I think we could do this here in Maryland and make a big difference.
Why don't you take a minute and do it?
Thank you. I appreciate that.
Go ahead.
So what they did, and again, the bill should be passing hopefully soon, is they said there's something that we think if we can start getting providers and carriers to use an electronic process, which is having the doctor having their electronic records that has a real electronic pre-auth. They can immediately log on, and it syncs to everything, so they don't have to go to everybody's site. It's much more uniform and streamlined, and it allows providers to actually sit with the patient, was similar to what Delegate Cullison was just saying, and say, let's pull up the drug, pop it in. What comes up is it says it's pre-auth. Now, there's something called real-time benefit check, which is like an app, just like we put on our phone. You purchase the app, put them together, comes up, it says Debbie Rivkin. It talks about what my deductibles are, my co-pays, what my benefits are, how much do I have left in my deductible, and it says, here's the drug, it'll say it needs a pre-auth. But at the same time, it'll also tell me 4 other drugs that don't require a pre-auth. What's even better, it'll tell me the prices of those drugs. So I have the opportunity to say, drug A is $45, drug B is $12, drug C is $5. And you can sit down with the patient at that moment and have a conversation about what drug is potentially from a cost perspective, a timing perspective, you want to prescribe. You want to do the pre-auth, you can still go through with the pre-auth. According to the study, or what Virginia said, the providers, the carriers, the PBMs, and the regulators all believe this is going to take away a lot of the problems in the system. It's going to streamline the process. It's not going to be perfect, but we're going to go a long way to getting a better process in place, and I would suggest that's something we should work on here in Maryland. Thank you for the extra time. I appreciate that.
Sure. Who's next?
Madam Chair, thank you for the opportunity, members of the committee. My name is Heather Cascone, and I represent PCMA and the nation's pharmacy benefit managers, or PBMs. I respectfully request an unfavorable report on this bill as drafted, as my other panelists have done so as well. I'd like to voice a specific concern on the bill's prohibition on the use of prior authorization when generic drugs are prescribed. And while we have heard a list of concerns from witnesses before me, I'd like to tell a slightly different or another story of the why prior auth is used. While we recognize the concerns raised by the sponsor and the panelists, the bill creates a carte blanche bypass of all of the meaningful review of safety checks and concerns by allowing unrestricted dispensing of generic drugs or an override based on the subjective opinion of the prescriber. Prior authorization can protect patients from drugs with a safety risk. They can catch things like drug disease contraindications, drug dosage errors, contraindications for pregnancy, drug age precautions, and a variety of cost savings protections for patients and plans, ranging everywhere from some examples from actual claims data that we've seen include overutilization of Tylenol through a generic drug called Vicodin, metformin and the risks that it brings with kidney failure from lactic acidosis, utilization review for drugs that treat ADHD since they are stimulants and are controlled substances, and present risk of abuse and misuse. There is clearly a very delicate balance here between patient access and affordability, and these decisions come with a big cost and safety implication. And so we should take the time to really fully address the concerns of the prescribers and the problems raised, but not give unilateral control in a time where healthcare costs are significantly on the rise. And we don't want to create equally dangerous risks for patients. It's for these reasons we must request an unfavorable report on the bill as drafted, but as my fellow witnesses have indicated, we likewise would be happy to work further on the bill. Thank you.
Are there any questions? Delegate Bandari?
Thank you. Madam Chair, question to Heather. In light of the challenges reported by many healthcare providers, such as rigid and non-productive formats, unclear approval criteria, lack of patient care, and excessive bureaucratic documentation requirement, why do you insurance companies question a doctor's credibility when they believe a specific prescription drug is the best treatment option for their patient? And I think, did the insurance company not like their prescription handwriting or doctor's font? I don't think that. But seriously, Madam Chair, what qualification do the individuals responsible for approving or denying prescription typically have? Can we have that accountability?
Sure. Thank you for the question. I appreciate it and the opportunity to answer. Ultimately, safety checks on prescribers don't purport to be a barrier, but rather a safety net for errors from well-meaning prescribers. PBMs employ a host of clinicians that review criteria with every drug that is covered and the reasons for why it is covered. And so when those reviews happen, they are already established by that clinical peer community within the house of the PBM.
You have a follow-up?
But still, I would love to ask again, what qualification, if the doctors, they are the one who are very credible, right? What qualification those person have who approve or disapprove the pre-authorizations?
Yeah, thank you. Under Maryland law, only doctors can disapprove in this instance, and so the clinicians that are working in-house of the PBM are in fact reviewing that criteria, making that decision on a denial.
But the research shows that everything when the doctor asks to authorize is not approved, right?
I would actually argue a separate story. In fact, our experience on, for example, step therapy, a type of prior authorization that exists, the vast majority of time, that patient stays content and continuing therapy on the first line medication that's prescribed through the step therapy protocol. Prior authorizations, we can agree that they can improve in the processes of how they work, but frankly, the reasons for why they are there are very valid. And so, we're happy to have conversations in making sure that the criteria involved in that decision-making is up to date with the most, reviewed medical literature. We feel confident that it is, but we're certainly happy to talk about making sure that it is regularly reviewed in-house.
Thank you. Gazzoni.
Thank you. I think this is probably a question for Deb, but whomever wants to answer. I'm trying to get a little better understanding on this. So could you please sort of walk through the e-prescribing how it streamlines the process for providers, and then also what are the timelines for this to become like a functional thing?
Be the best because I just was learning what happened in Virginia and have read lots of articles. I've never actually used it, and I don't know if you have a better feel for it, but I will give my best answer. What it's supposed to do is give the real-time ability for a provider to log in, and we are supposed to have this today through the law that passed in Maryland, so that when you pull up for a drug that says there's going to be a pre-auth, there's supposed to be a list of questions, and it's supposed to be click, 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 yes or no. And if you click yes for the actual questions, you get an automatic adjudication, you're good, you get the drug. So the goal is you answer the questions because your patient actually meets the criteria, it's done. When there are some no questions or some additional, you might have to submit additional information. When you have it on and sometimes that's done through fax, right? And many of providers do not use the electronic system we have today. They choose instead to use fax. It takes a longer process. That's their right. It's under the law to allow them to do that. So when you have the electronic pre-auth system, which I'm describing the way I understand it, you don't have to go into Cigna's website or Aetna's website. You can pull up exactly what you need, go through the process, submit. If you have to do additional information, it can be submitted right then because you have the medical records, and that's how the process works. This app that you attach to it also gives lots of information about the patient in themselves, so that you can see exactly what their costs would be, what other meds are on their actual formula, so you don't have to go searching for it. It's pulling more information so you can have a better discussion with the patient at the time of actually prescribing. I hope that helps answer.
Yeah.
Sure.
Is this sort of, does this become this sort of centralized portal, or does it get us, or is it just getting us closer to it?
I think in a way it is a centralized portal. Now I will say that what the proponents' bill does is there's a study to look at trying to streamline this. I maintain this is the way I think it should be streamlined as opposed to doing something through CRISP. or somewhere else. This is something that actually Medicare is requiring right now of all carriers. They have to use e-prescribing, I think, have the ability to have e-prescribing and real-time benefits as of this year. So it's something that is going to be used beyond just Maryland. It should be used everywhere. There are a number of states, I have it in my testimony somewhere, that have already moved in this direction. But what Virginia said is we'll give everybody 2 years to get up and ready. It's something we can't turn on tomorrow. It's going to take a little bit of time. Thank you.
Delegate Shalega.
Thank you, Madam Chair. Thank you all for being here. Matt, this question's for you, and I actually was surprised to hear you say 21, I think you said 21% of physicians reported 21% unnecessary care. I'm surprised it's not higher with all the defensive medicine that physicians have to practice, but go ahead.
Delegate Shalega, that, yes, is absolutely true. And this is from the AMA and their internal study. This is just one of many studies. This is the NIH study. There was another one that was done by Johns Hopkins that found basically similar numbers. But there's a lot of different reasons for that, which I think this is sort of part of the context of why we need to continue to talk about it. The most common cited reasons for overtreatment were, 1, fear of malpractice at 85%, patient pressure request 60%, difficulty accessing medical records, 38%. Potential solutions identified were training residents on appropriateness criteria, 56%, which we've sort of been talking, and I think the value of prior auth. Easy access to outside health records, 52% identified that. And more practice guidelines, 52%. I think it fits right into the idea that prior auth is a valuable tool to make sure that appropriate care is getting to patients.
Yeah, I guess I wouldn't see it that way, but I also then ask you to comment on 70% of prior auths are overturned. That's a 70% failure rate.
So I will say to that, and I'm glad you asked that question. The vast majority of prior auths that are denied are because the information's not put in correctly, as in we don't get the right date of birth, or it's a clinical error, or it's something, a checkbox was not done correctly. On the appeal or asking for more information, it's cleared up most of the time.
So how many of the prior auths are the ones that we're all hearing about? And I mean, we all know people that struggle with this prior auth issue, and they can't get the drugs they need, especially, critical asthma drugs and other things. Well, it's got to be a large percentage of that. It can't be that many human errors.
I'm not going to pull a random number out of the air. I don't know.
I appreciate that.
But I will say, in the emergency space, by Maryland statute, if you request a drug in an emergency setting, it has to be done within 24 hours. So we already have some protections in it. I can't speak to what the actual number is after the back and forth in the appeals and grievance process, but I'm sure we could probably engage with the MIA and try to find out further information for you.
That sounds good, and I noticed that the bill actually extends that emergency room care into post-evaluation and post-stabilization, so that part of it must be working. Thank you.
You notice I'm being a little flexible with a number of questions you're asking, right? But let's not do that because there are many, many bills coming next week. But this is an important bill, and I think that you'll see the interest in this room. And the questions were great, Delegate Shalega. Delegate Taveras, followed by Delegate Collison, followed by Delegate Kipke.
Okay. Thank you, Madam Chair. Well, now is more appropriate. I had it written down. The question is with regards to generic drugs. What is the problem with having generic drugs being exempt from pre-authorization? Is there a particular issue?
Who's the best person to answer?
I'd be happy to try to answer the question. Thank you very much for it. Generic drugs, although very well known and recognized as being safe and less expensive alternatives, in themselves still potentially pose safety risks to patients depending on the category. So for example, I mentioned the use of metformin. I think we all recognize that we trust our prescriber to treat us and prescribe appropriately. I can tell you personal anecdotal experience, when I was pregnant and I was diabetic, my endocrinologist wanted to put me on a certain set of drugs and said, make sure you talk to your obstetrician before you fill these prescriptions because they want to make sure that they are appropriate. Even generic drugs carry risks in certain patients for certain reasons. Likewise, there are a set, I could give you follow-up with plenty of examples of various categories. Likewise, there are also cost considerations with regard to generic drugs. There are many drugs in a certain class where the cost ranges dramatically. Antidepressants, for example, typically range between $5 to $10 for a 30-day supply. One, however, is $135. And so why we consider EPA and electronic prescribing so valuable in the physician's practice is so that they can have that information at the point of prescribing when the patient is sitting in their office, and they can make a decision coordinated with the patient with cost and potential prior authorization in mind. I hope that answers your question.
Okay, thank you. We have Delegate Kipke followed by Delegate Hill.
Thank you, Madam Chairman. Heather, the safety things that you're bringing up, and when you did your testimony, you went through a long list of contraindications, you went through a long list. I'm just curious, don't PBMs already look for that without prior authorization? So if I have drugs that interact improperly in my body, and maybe I didn't tell a doctor about it or whatever, like, why is pre-authorization then necessary? Because I'm under the impression that you're looking for that anyway.
Correct, and thank you for the question, Delegate Kipke. You are correct in that the system of interoperable communication that exists between pharmacists and their pharmacies and other pharmacies was developed and still operates based on a PBM communication tool that allows pharmacies and pharmacists to see what drugs are being taken by what patients, regardless of where they filled those drugs. Prior authorization, though, happens before that drug claim essentially gets to the pharmacy. And so we are trying to prevent the type of delay that patients experience when a prior auth then gets to the pharmacy and the pharmacy then has to call the prescriber to tell them that a prior authorization existed. We would like to have those types of checks acknowledged and resolved before the patient even leaves the doctor's office and gets then the claim to the pharmacy.
It was mentioned earlier, I think, by Delegate Hill, that some of these doctors told stories where people died because of the delays, and their stories are very compelling. The medications that they were seeking, I mean, I think Dr. Hiller, somebody mentioned that if a physician had done this, they're liable from a liability perspective. Are PBMs liable in any way for denying care and the negative outcomes that come from that?
I don't know the answer to your question, Delegate. It's an interesting point, but unfortunately I don't know. I don't want to speak out of turn.
You represent PCMA, right?
Correct.
So I would think that you would, PBMs get sued a lot. If you just Google it, every day it seems like they're getting sued by everybody. But I didn't see anything about, denying of care and the negative outcomes. You don't know whether or not that's possible?
Understanding, but I can't say for sure.
Could you let the committee know?
I'd be.
Thank you.
Thank you.
Thank you, Madam Chairman.
You're welcome. Delegate Hill.
Thank you, Madam Chair. So I heard a theme. Matt, you talked about how you care about the patients too because they're your beneficiaries and you want them to have the most cost-effective care, most cost-effective medication, I think is what you said. And Heather, you talked about how you guys think it's really important that when the physicians sit down there in that doctor's office and spend that extra time they're not getting paid for to discuss the cost of the care with the patient, that should really be part of the conversation. And Deb, you also made reference to how important it was that somewhere between the insurance company and the PBM, because it wasn't clear when you were talking who's making the decisions about prior authorizations, it's the PBM or it's the insurer, and it's, again, one of those things. But you also talked about the importance of the cost and how if we had this Virginia system, everything could work a little bit faster. I've used that system, and it doesn't change the amount of denials. It doesn't change the amount of time that it takes, except by a little bit. So what I'm trying to find out is just, the straight question is what you're saying is that your prioritization of minimizing the cost of care should outweigh the clinician's decisions about what is in the best interest of the patient's health. Is that what you guys, I want to make clear? Okay.
But I'm going to speak for myself. What I was trying to say is there are other options, and part of what we should be looking at is let the patient know, oh my goodness, there's a drug that's cheaper. But that doesn't mean that's what pre-authorizations are about. There's a lot of things about a pre-authorization is to make sure that based on the literature, and I hate to be talking to a physician about this is making me a little nervous, but when we know what the criteria is nationally, vetted criteria, because we have requirements in law of what needs to be done, they're national, they're peer-reviewed, et cetera, that we ask the questions like, it says no patient should have this under the age of 14. So the question is the patient over 14? No one should have this with a BMI under X. That's the question. So that's what we're looking at. We're looking at quality as well, the care of the patient to make sure there won't be any irreversible or impacts to their health. It's not just a cost implication. I cannot agree to that. There are many times we're looking at what will be make sure the patient's on the right med and there won't be any negative impacts to the patient.
May I follow up?
One more.
Thank you. And so under those circumstances where you're concerned that the provider of care is going to cause damage if you weren't in there to jump in the middle and make them think a second or third time for 2 or 3 weeks to decide if their decision is correct, what responsibility do you take when your decisions of denial and the process of getting that reversed leads to loss of time of work, emergency room visits, etc., causes more damage? Since you're trying to avoid damage to the patient, what responsibility do you take when you cause damage to the patients?
Delegate Hill, we have tried, the system's not perfect, and we've tried to put a system in place in this state over a number of years where we've had the insurance commissioner, the legislators, and all interested parties work together on this process. And part of the process that we put in place is not only to try to come up with reasonable timeframes to get this done, and then start with an automated process we're hoping to get to, which isn't working really great. I'm hoping to get even better, that we had with the benchmarks that the Healthcare Commission put into law a number of years ago, so we would have quicker adjudications. We also have the ability to have exceptions policies. So for us, if on all of our pre-auths, and we say, is the person of a certain age, certain, all the criteria, do they have their labs or whatever it is, there's also questions that say, would this medication be contraindicated for that individual? Are there other exceptions that we need to hear about to know this isn't the appropriate drug? And that's how the time frame isn't work. I don't disagree with anything we heard. They all happen. But I'm trying to figure out a way that we can marry the two together so we can have a better process, but we can also look at those, to make sure that the right drugs are given at the right time, because we do find times when the patient isn't meeting criteria for a particular drug. But we will always have that ability to have an exception and a conversation with a physician about those exceptions. And we have that on all of our policies, and we have it for all of the drugs. They're either in the pre-auth or we have separate criteria for the exceptions policy. You can always call the medical directors internally at the company as well and have a conversation. That's part of the law.
Okay, thank you. So we have Delegate Bagnall, followed by Hutchinson, followed by Wood.
Thank you, Madam Chair. I think this question, again, is for Heather. I apologize that I'm asking you this, but we don't have testimony from the Board of Pharmacists or from the independent pharmacists. They have not taken a position on this. So I'm just asking why the PBMs are concerned about pre-authorization of generic drugs when it doesn't appear that other pharmacists have that same concern. So if you could speak to how that is different within the PBM's world so we can understand it.
Clear, pharmacy benefit managers are not providers in the same way that pharmacists are. Pharmacy benefit companies are subcontractors of carrier plans. Our clients include health plans, employers, government, state of Maryland here, for example, hire us to manage the pharmacy portion of their health benefits plan. And so in this instance, we act as an arm of the health plan and not as much as a dispensing entity like a pharmacist. Does that answer your question?
I think it does. Thank you.
Delegate Hutchinson.
Thank you, Madam Chair. This question is for Matt, and I apologize, it's been a long day if I didn't hear you correctly, but I thought in your testimony you said, look at the fiscal analysis and the cost is significant, or the financial implication is significant. Could you, I didn't quite see that in there, so could you share that with me?
So it is on the next page 10 and 11 of the fiscal note in the state expenditures portion. It says DBM advises that the bill increases cost to the state plan by 3 to 8% annually, which is a range of $36 million to $96 million for medical expenses. And it says that at this time, DBM cannot estimate the impact on prescription drugs. However, if the cost increase is the same for prescription drugs as it is for medical expenses, the state plan would incur an additional $24 million to $63 million in costs annually for prescription drug expenses. That, I think, is concerning on its own. I don't know what end of those ranges it could be, but I do know that this bill is going to come along with a cost. It also says after that, besides the state health plan, that small businesses that purchase fully insured health benefit plans, their costs will increase as well.
Thank you.
Thank you.
Okay. Delegate Riley.
Thank you, Madam Chair. Yeah, this is for Deb. I hate to beat on the app. I mean, it could be a great, wonderful thing, but I heard similar, I think, to what Delegate Hill heard, and I'm not sure that you answered her question, at least in my understanding. So when you talked about the app, you said that the thing that triggered the denial for when they went to get the prescription, filled. So you have a denial, and you said that you see that on the app, and you said it's probably the top drug, and that's why it's being denied. That's why it was being denied. So then automatically that you would say, okay, so then now the physician sits down with the patient, looks at all the other options. And I took it of what you said, okay, well, if they pick another one, like one down or the next one down, then that would automatically be filled and they could bypass the pre-authorization. So, if they wanted to stay with the most expensive drug. It's not always the most expensive. Okay, or the one that. The drug that's
It's expensive.
Okay, so that's good to know. So it may not be the one that's most expensive.
Wait for the question to be finished.
Okay, that's all right.
It's been a long day, it's all right, but let's have a little order.
Yeah.
Go ahead.
Okay, so, but if they still wanted to do that first drug that they asked for, that they've had before, but now they want to stay on it because it's working, but you're going to make them go through the process again, which takes several weeks in some cases, because they didn't pick one of the other drugs.
Okay, you can go now.
Now I got to remember everything she said.
The pressure is on.
Sorry.
So it doesn't necessarily take several weeks, number one. Sometimes, the reason why something takes longer is because if you checked off a box and you said, we ask a question, sometimes you have to send in medical records or additional information. And that takes longer because you have to send them in. And right now, a lot of them come in by fax or mail and others.
But didn't they already do that when you have
So lots of times when these yearly reviews for a drug, that we ask some questions, but it's a lot, from my understanding, it is not as comprehensive of questions as it was for the initial pre-authorization, but it's mostly asking to make sure the patient is still well maintained and give some medical notes to show that the patient is still doing well on the drug and there's no contraindications, and that they've had if they needed blood levels or they had kidney check, that those types of tests have been performed and they're doing well, which may mean that you have to submit something to us so we know what's happening. But it's supposed to be, and for the ones I've seen, a less rigorous request. Why it's taking longer, I can't explain from the examples, but that's what usually happens.
Okay, thank you for that explanation.
Delegate Collison.
Thank you, Madam Chair. So I have a question after all. Actually, I have two, but they're real quick. One is, can you share with the subcommittee an example of a pre-authorization form so that when we meet, I can put it on the screen so people can actually see what's being asked on the pre-registration form? Can you do that for us? And number two, Matt, you talked about the cost that's in the fiscal note. Who ultimately pays that cost?
It's not going to be the carriers, Delegate Collison. It's going to get passed through and increase premiums to the beneficiaries and all your constituents.
Okay, thank you.
Any other questions? Okay, so I don't see any other questions from the committee. So we know there's a cost. There's a cost to everything we do in this committee, but we try to find a balance, especially when you have doctors that take the day off, as busy as they are, oncologists, pediatricians to come and give testimony because they're motivated by their frustration for the care of their patients. You interrupt the care, you divert resources from patients and complicated decision-making, and sometimes people lose their lives. I know 2 cases of someone that needed pain medication. He had surgery 2 weeks ago. Got home on Friday from Hopkins. Couldn't get the pre-authorization for the medication he needed, and it was horrific for him on a Saturday with the pain in his care. I know of another one that was addicted to drugs. It was a Friday. They needed immediately to try to get this drug for this person. The person passed away on Saturday. So wherever the truth lies, right, there's a problem. And you can hear it by all the concerns of the people here. There is a cost. There's also abuse as well. We know that, like with everything. But we have to try to find a solution. So what I would ask you respectfully is that you would give the committee, especially council, and our council today is Ms. Lisa Simpson, the bill from Virginia, who actually made up the group. They came together so that we could do something similar in the interim. But meanwhile, I would like you to look at certain drugs that are important and you heard some of that today. I know you don't want to do the whole bill, and we do have 2 houses, right? And we can pass it. And I think that there is interest. But I know there's another house, and we want to get it right. But there's something that I want you to be able to find something that you can do for some of these people, because the pain is real for a lot of them in their care as well. And if you will be so kind as well and provide the form that Delegate Collison requested, and then for the, is it Ms. Heather? Right, will you please follow up with Delegate Kipke and submit to the entire committee? So everything that I requested, I'd like you to submit it to the entire committee. This bill is going to be assigned to the insurance subcommittee, which I know Delegate Collison is an expert on these issues. But I think that the testimony was compelling and there was interest from everyone here to be able to find some solution as well, okay? We do have for the committee 3 more witnesses virtual. I ask for your patience while we bring them up so they can give testimony as well. Thank you so much for your patience and everyone that has been here waiting as well. We appreciate it. This was an important bill. Thank you. Yes, I asked already. Yeah. So we have Krista Frederick, Jennifer Dorr, Larry Green, and they're testifying virtually and they're testifying favorable. So let's start with Mr. Green. Will you be so kind and please provide your testimony?
Thank you, Madam Chair. My name is Larry Green. I'm a board certified dermatologist in Rockville, and I'm here representing the Maryland Dermatology Society and the American Academy of Dermatology. I'm here requesting a favorable report on House Bill 305. We just heard a lot of testimony from people against House Bill 305. And I'm just going to start by saying that's pretty classic with my experience with PBMs and insurers. They want to delay. You've just experienced some of that because they want to work on things, change things, try and change this medication, delay. I would suggest you a favorable report and then work on improving things with them. I'm going to show you what it does to me. I'm going to talk about reauthorization. Delegate Carlson wanted to see an example of the process we do. We do this 3 times a day. This is the office notes for the patient as well as all the forms we have to fill out. Every day we do this 3 times a day. This is for reauthorization. This is for patients who have been stable on a medication for a number of years, but every year we have to renew it. And every year I have to send all this material. Now, they suggest, even though once they approved it, every year they suggest we change the medication for the patient. I don't know what the reviewers are thinking. We already have an FDA-approved medication, but the reviewers who review the literature, like they said, are suggesting we change medication that in our case, sometimes we would think is medically negligent. So they're suggesting we change to something that's medically negligent. We have a patient who's stable, and if that patient goes off the medicine, which often happens because they don't approve it, that patient is going to get worse. And think about the costs of the healthcare system as that patient, every day of mine, has to go off medicine and wait to get it reauthorized, even though it takes much more time. The financial cost to a practice is about $40,000 per year, according to the dermatology administrators. And after 3.5 work hours a day, I spend an hour and a half a day on these forms. Imagine how much more patient care we could provide during that time. Thank you for your time. I urge you to support House Bill 305 as it is.
Thank you very much for your time. Who would like to be next? Why don't I just call on Krista Frederick? Can you unmute yourself, please? Ms. Frederick, can you hear me? Will you be so kind? Thank you. Well, you can start your testimony. I can't. Go ahead.
Can you hear me?
Yes, I can.
My name is Krista Frederick. I'm a physical therapist. I reside in Montgomery County, and I'm also a private practice owner with 8 locations and 50 employees in Maryland. We serve over 5,000 Maryland residents a year. Only 12 years ago, my practice required 7% prior authorizations. In 2022, that number is 70% of our patients requiring authorization every 2 to 4 visits. These disproportionately affect patients on Medicaid and lower socioeconomic population on higher utilization plans. The burden of processing these requests this year resulted in us dropping the insurance of 1 Maryland Medicaid HMO and 1 commercial HMO, limiting access for much of our community as we were one of the only providers in our area accepting those plans. This was a difficult decision because we really pride ourselves on giving access to all the members of our community, but we just couldn't keep up with the prior authorization demands this year. Requesting authorization for physical therapy involves filling out forms by hand every 2 to 4 visits, including several measurements as well as forms that the patients need guidance to fill out. And it can take half of their session. So if every 3 visits, someone is being required to fill that form out. If this was electronic, it would be much easier if there was a single point of entry for the therapist. As well as the point on being able to have a phone call from the provider ahead of time. Our therapists get a denial by fax from a provider who's usually not a physical therapist. We have 48 hours to appeal the denial. And if the therapist is out of the office, we may not get to that in 48 hours. They play phone tag with the provider or the insurance company on the other side. And frequently it results in a patient not getting services they should because we can't get in touch with somebody fast enough to get the appeal process started. So we are in favor of those provisions in the bill.
Thank you for doing business in Maryland, and thank you for coming today. I appreciate it. Dr. Jennifer Dorr.
Good afternoon, and thank you, Madam Chair and honorable members of the committee. My name is Dr. Jennifer Dorr, and I'm a child and adolescent psychiatrist. I'm here representing both Maryland Psychiatric Society and Washington Psychiatric Society, and I'm asking that you support HB 305, as this is a priority bill to help to eliminate barriers currently in place that do not allow my patients to receive timely mental health care. As a child and adolescent psychiatrist, I'm on the front lines helping youth to battle the current mental health crisis. I'm able to make treatment recommendations based on my knowledge of the patient and the expertise and training I have obtained, which is 17 years of training post-high school. As an example, I had a 17-year-old patient who had an inpatient psychiatric hospitalization for suicidal ideation. They were started on an additional medication while inpatient, though there was a prior authorization requirement for outpatient medication. So this patient went several days without being on the medication. This is incredibly dangerous and unfortunately not an isolated incident. Further, studies have shown that patients are at an almost 12 times increased risk of suicide within the first 3 months following hospitalization. So delaying medication is life-threatening. It's my professional duty to know contraindications to medications I prescribe and to stay up to date on literature in my field. Also, I can see other meds my patient is prescribed. I don't need a PBM to tell me that. Further, none have actually ever told me that. Also, when cost is an argument, yet generic meds are not approved versus a name brand medication that for some reason is on an insurance company's formulary that's obviously much more expensive is approved, that doesn't make a lot of sense. I'm sorry, but I don't think it's good enough to say we'll continue to work on this because the youth mental health crisis is emergent and happening now. There simply is no more time. HB 305 works to help move prior authorization requirements to only those that are necessary.
You can finish. You could go ahead and take your time. Go ahead.
Thank you. And regarding the argument that prior authorizations ensure patient safety, my question is, wouldn't I, as a child and adolescent psychiatric physician, be the most concerned and diligent about my own patient safety, particularly more so than a physician, either approving or denying my requests that may not be in my specialty? Again, a physician who is not a child and adolescent psychiatrist may deny my patient their psychiatric medication, and they have never even met my patient. Thank you so much for allowing me this opportunity to speak with you, and I ask the committee for a favorable report on HB 305 to help to eliminate a barrier to timely mental health care treatment.
Don't go anywhere because we do have questions for you. First, we have Delegate Riley, followed by Delegate Bagnall. Delegate Riley.
Thank you, Madam Chair. My question is for, I believe, I can't read my glasses, Mr. Green, Larry Green?
Yes.
Yeah.
Dr. Green? Yes, so you had mentioned, I think, kind of the point that we were asking earlier. So why would you think that year after year, they're trying to get you to change the medication that you're prescribing? What do you think the reasoning is?
That's a question you would have to ask them, I would think. I mean, as a physician, I just know how frustrating it is when I have a patient who's been using the same medication for 5 years, 10 years, is asked to change it. And I know the patients I treat a lot of psoriasis, they're clear. And their psioriasis for the first time in the last 5 years that they've been taking medicine is clear. But I have to go through this form every year and they ask me to change it. Personally, that's something you have to ask them. I personally think it's because they get a bigger rebate, but I don't want to go there. That's my own opinion, and that I have no idea if that's true. But I just know that I'm being asked to change a medication that saved their lives. And these patients then go off the medicine because they can't get it, and their psoriasis is flaring up. And they end up back in my office costing healthcare dollars. And it's just very sad.
Okay, I think you somewhat answered our question in surmising. Just to follow up real quick.
Absolutely.
You had said some of the times the prescription that they want you to give them, you feel would be detriment to the patient. Can you explain what you meant there?
Correct. Sometimes the medication request is a medication the patient's already failed in the past, because I know their medical history. And they see it, but I guess they really don't read all the stuff we send them. But sometimes they request a medicine like methotrexate, which we don't use anymore to treat psoriasis. It's a chemotherapy agent. We stopped using that when the biologics came. Or sometimes they'll request a biologic that's really contraindicated and not really safe for that patient.
Okay, thank you very much. Thank you, Madam Chair.
My pleasure. I have Delegate Bagnall, followed by Delegate Shalega.
Thank you, Madam Chair. And this question is for Dr. Dorr. Can you speak to the outcomes of management drugs for these complex mental health issues, and what a delay in these management prescriptives can do for the outcome of your patients?
Absolutely, thank you. So I have several examples, but I have another example of an 8-year-old child who was on a medication. And then, you know, when the year came up, it was time for another prior authorization and it was denied. And the reason I was told it was denied, it was not FDA approved for one of their diagnoses. However, it was FDA approved for a different diagnosis. So, and I clearly put all of their diagnoses on the form. That delay caused the patient to be irritable, to act out, to not do well in school, to cause his mother a lot of stress, and to really have mood dysregulation and a real deterioration in his mental health status. And I think, you know, eventually when I called them and I said, listen, I got this denial. I don't understand. It's FDA approved for this other medication. Oh, okay, sorry. And they approved it, but that shouldn't be the standard, and that's the standard. I also have another patient who switched insurance companies. She's 17. She has severe suicidal ideation, self-harm by cutting, ADHD, and the insurance company wanted to switch her medication because they had it wasn't on the formulary of the new insurance company. We appealed it, they still denied it, we tried, and the other medication was not as successful. So I think what it really comes down to is it can mean life or death for my patients. And I think 48 hours, several days, I mean, that's not enough. I mean, that those several days could mean a patient deteriorates and takes their own life. And I think that's just really unacceptable.
Madam Chair, if I could have a quick follow-up.
Sure.
Can you also speak to when these pharmaceuticals are reinstated, is the impact immediate, or is there a ramping up that's required?
That's a really great question. So it depends. So if it's something as simple as a stimulant, it could be impactful. However, I would have to start at a lower dose because the patient's been off of it so long. So then it would slowly have to ramp up their dosage so that they could then tolerate the medication. If it's something like an antidepressant, an antipsychotic, it's not immediate and it takes a while to get back in their system. And that's it. And again, we have to start at lower doses if they've been off of it. Because then if we start at the same higher dose, the side effects are higher.
Thank you, Madam Chair.
Delegate Shalega? Oh. Okay. Well, I just want to tell both witnesses there are no other questions. Thank you for your patience. You are and were our last two witnesses for the day, and you were very generous in staying to the end, and we really appreciate you. And we are going to be looking at this bill closely, and as you can tell, there's a lot of interest, and we do care, okay? Thank you
Madam
for
Chair.
what you do.
Thank you. It's time for dinner with Delegate Kerr now.
All right, take care. Bye-bye. Bye-bye. Thank you. Thanks so much. If you could take us off and then just give me 1 second, the committee. Thank you, everyone, for coming. This actually concludes, 1 second, the bill hearing on House Bill 305. Thank you very much, everyone. So Delegate Kerr, where's Delegate Kerr? You owe us dinner, huh? Okay? I don't know. Can I just tell you, not tonight. Wait a minute, that does not count. You have